Welcome back to the Deep Dive, where we plunge into complex topics, sifting through the details to unearth those essential insights that truly make you well-informed. Today, we're embarking on, well, a really ambitious journey to truly master the intricate world of central nervous system pathology. We're going to peel back the layers of brain and spinal cord injuries, diseases, and disorders, understanding not just what happens, but why it matters for human health, giving you the kind of deep, intuitive understanding that elite professionals possess.
It's a profound journey, really, into the very core of what makes us who we are and what happens when those incredibly complex systems are disrupted. The CNS, the body's ultimate command center, it's vulnerable in unique ways, and its pathologies are as diverse as they are profound. We'll be connecting the most subtle cellular responses to the dramatic macroscopic changes we see, exploring everything from genetic predispositions to environmental insults, and tracing the paths of various diseases, all distilled from foundational sources like ROBBINS and pathologic basis of disease.
Get ready for an unparalleled exploration, where every essential nugget of knowledge will hopefully give you that aha moment of deep understanding. Okay, let's unpack this. We often think about organs as a whole, but the brain is truly a city of specialized cells, each with its own job. So when something goes wrong, how do these individual cells, the neurons, the communicators, and their glial partners, the support crew, how do they actually react to injury? It's where the story of CNS pathology truly begins, isn't it?
That's exactly right. And unlike other tissues in the body, each cell type within the central nervous system has a remarkably distinctive and specific response to injury. Understanding these unique cellular reactions gives us crucial clues about the underlying mechanism of the damage and, importantly, the specific disease at play. It's like these cells leave their own unique fingerprint of what went wrong.
Okay, let's start with neurons then. They're famously sensitive. What makes them so vulnerable, and what does their injury look like, both acutely, meaning suddenly, and maybe over a longer chronic period?
Neurons are indeed incredibly delicate. Think of them as high-performance sports cars. They're constantly working, demanding a continuous, uninterrupted supply of oxygen and glucose to fuel their intense metabolic activity. And compounding this, once mature, they are largely postmitotic, meaning they generally can't divide and replace themselves. So if a neuron dies, it's usually gone for good. This combination makes them unusually susceptible to injury from anything that cuts off their fuel supply, and also prone to accumulating misfolded proteins, which, as we'll see, is central to many neurodegenerative disorders. The loss of even a relatively small number of critical neurons can have a devastating impact on brain function. Now, when a neuron dies acutely, say from a sudden lack of oxygen like in a stroke, it undergoes a dramatic, irreversible change. Within as little as 6 to 12 hours after an acute insult, severe lack of blood flow, profound low blood sugar, trauma, these neurons develop a distinct red appearance under the microscope. This red neuron is pathology's grim confirmation of severe, sudden cellular distress. Its cell body shrinks, the nucleus condenses, its normal internal structures vanish, leaving this deeply pink-stained, shrunken ghost of a cell. This unique marker tells us definitively that the cell is gone, it's irreversible, and it happened fast.
Wow, so it's a quick, decisive change. What about the slower, more chronic kind of damage? How does that look?
Right, so in contrast, subacute and chronic neuronal injury, what we call degeneration, is seen in progressive diseases that unfold over months to years. Think of conditions like amyotrophic lateral sclerosis or Alzheimer's disease. Here, the process is much more subtle initially. There's often an early loss of synapses. These are the critical communication points between neurons. Sometimes this is even due to what looks like aberrant pruning, where the brain mistakenly removes healthy connections. This is followed by a more selective, gradual cell death, often affecting specific groups of neurons that are functionally linked. Early on, it can be really tough to spot actual neuron loss, so we often look for changes in the supporting cells, particularly astrocytes, a process called gliosis, which is usually the first major indicator of this slower progressive injury. In these cases, the cells typically die by a more programmed process called apoptosis. There's also a fascinating specific response called the axonal reaction, or central chromatolysis. This occurs in the neuron's main body when its long, wire-like projection, the axon, is cut or severely damaged. It's essentially the neuron shifting gears, ramping up protein synthesis in an attempt to regenerate the damaged axon. Under the microscope, you'd see the cell body swell and become rounder, its nucleus get pushed to the side, and its internal protein-making machinery disperse. It's a sign of a neuron trying desperately to heal itself.
like the neuron's emergency repair kit activating. What other interesting changes or sort of footprints do neurons leave behind that tell us what happened?
Neurons can accumulate a variety of materials within their cytoplasm, forming what we call subcellular alterations and inclusions, which are incredibly important diagnostic clues. These can be simple age-related pigments like lipofuscin or abnormal buildups of proteins or carbohydrates, often due to genetic inborn errors of metabolism where specific enzymes are missing. Viral infections also leave distinct calling cards, like the tiny Cowdry bodies in herpes or the infamous Negri bodies in rabies. But perhaps most significantly, many neurodegenerative diseases are characterized by specific abnormal protein accumulations, like the neurofibrillary tangles in Alzheimer's disease, Lewy bodies in Parkinson disease, or the strange vacuolization seen in Creutzfeldt-Jakob disease. Each is a specific signature of disease. And on a broader scale, if an axon is completely disrupted, the part of the axon furthest from the cell body will degenerate, a process known as Wallerian degeneration, important in both central and peripheral nerve injury.
Okay, so those are the neurons. Now, what about their crucial partners, the astrocytes, these star-shaped support cells? What's their role, and how do they respond when things go wrong?
Astrocytes are truly indispensable. They're the brain's metabolic workhorses, acting as crucial buffers and detoxifiers, managing the environment around neurons. Their delicate foot processes also form vital barrier functions around blood vessels and near the brain surface, helping control what gets in and out. Their distinctive response to almost any form of CNS injury, regardless of the cause, is called gliosis. Think of it as the brain's equivalent of scar tissue formation, and it's often the most important microscopic marker of brain damage. In gliosis, astrocytes undergo both hypertrophy, meaning they get bigger, and hyperplasia, meaning they multiply. Their nuclei enlarge, become more prominent. And the cytoplasm stains intensely pink due to increased amounts of GFA, or glial fibrillary acidic protein, which is their specific structural protein. These cells then develop numerous stout branching processes, becoming what we call reactive or gemistocytic astrocytes. What's fascinating is that we now know there are at least 2 reactive astrocyte subtypes, which, despite looking similar, have distinct gene expression patterns and can either promote injury or actually facilitate repair.
That's a crucial distinction. So they can be good guys or bad guys in response to injury. Are there other ways astrocytes get injured or show signs of disease?
Absolutely. In acute injuries like severe oxygen deprivation, low blood sugar, or exposure to toxins, astrocytes can swell up, similar to how other cells react. Then there are Alzheimer type 2 astrocytes, which, confusingly, have nothing to do with Alzheimer's disease. They were simply named after the same neuroscientist. These are unique gray matter astrocytes with unusually large nuclei 2 to 3 times their normal size and a pale, clear center, often containing a small droplet of glycogen. They're primarily seen in conditions where there's high ammonia in the blood, such as chronic liver disease or certain genetic metabolic disorders. Astrocytes can also form various cytoplasmic inclusion bodies, which are important clues. Rosenthal fibers are thick, brightly pink, irregular structures found within astrocytic processes. They're typically seen in areas of long-standing gliosis and are a characteristic feature of a benign brain tumor called pilocytic astrocytoma, but also abundant in a rare genetic disorder called Alexander disease. More common are corpora amylacia, often called polyglucosan bodies. These are small, round, subtly blue staining structures with concentric layers found in the end processes of astrocytes, especially near blood vessels and the brain surface. They're basically accumulations of sugar polymers, and they tend to increase with age, thought to be the degenerative change. And finally, similar structures called Lafora bodies are found in neurons in a specific form of epilepsy. So even these support cells leave distinct fingerprints of different pathologies.
Okay. Now, what about microglia? Are they like the specialized immune cells of the brain kind of patrolling for trouble?
Precisely. You've hit on their core role. Microglia are indeed the brain's resident macrophages, its dedicated immune surveillance system. They actually originate very early in embryonic development, distinct from other immune cells. At rest, they're beautifully branched, constantly extending and retracting processes, covering distinct, non-overlapping territories, almost like a mosaic. Their roles are far more critical and diverse than just simple immune surveillance. What's truly groundbreaking is that during brain development, microglia are actively involved in pruning unused or weak synaptic connections, shaping the very circuits of our brains. And here's where it gets really interesting. Aberrant reactivation of this developmental synaptic pruning process has recently been implicated in a number of profound brain diseases, including schizophrenia, various types of encephalitis, and even neurodegenerative disorders like Alzheimer's disease and frontotemporal dementia. It's just these cells, when dysregulated, can start trimming away healthy connections.
That's a fascinating link. So, what happens when they do detect injury or infection? How do they respond?
When injury occurs, microglia are among the first responders.
Hmm.
They undergo remarkable changes. They proliferate rapidly, their nuclei become elongated, and they can form dense aggregates around small areas of tissue necrosis, which we call microglial nodules. They also have a unique ability to congregate directly around the cell bodies of dying neurons, literally engulfing them, a process known as neuronophagia. It's important to remember that in areas of significant inflammation, blood-derived macrophages, which come from outside the CNS, can also join the resident microglia, contributing to the overall immune response.
Are there any other crucial glial cells we should talk about, and how do they respond to injury?
Yes, absolutely. We also have oligodendrocytes and ependymal cells, each with their own specialized functions and distinct responses to injury. Oligodendrocytes are the cells uniquely responsible for creating the myelin sheath around axons in the central nervous system. This myelin is vital, acting like the insulation on an electrical wire, allowing for rapid and efficient nerve impulse transmission. Injury or programmed cell death, called the apoptosis of oligodendrocytes, is a hallmark feature of a whole group of conditions we call acquired demyelinating disorders, with multiple sclerosis being the most well-known example. It's also central to certain genetic conditions known as leukodystrophies. These cells can also become targets for viruses, harboring viral inclusions, as seen in progressive multifocal leukoencephalopathy, or PML. And fascinatingly, in a condition called multiple system atrophy, or MSA, these oligodendrocytes are found to contain specific protein accumulations, glial cytoplasmic inclusions, primarily made of osteonuclein. Finally, ependymal cells are the ciliated, columnar epithelial cells that form the delicate lining of the ventricles, the fluid-filled spaces deep within the brain. Generally, they don't show dramatic or very specific reactions to most types of brain injury. However, if there's significant inflammation or pronounced swelling of the ventricles, this ependymal lining can be disrupted. This disruption then triggers the underlying subependymal astrocytes to proliferate, forming small irregularities on the ventricular surfaces that we call ependymal granulations. In rare cases, certain infectious agents, particularly cytomegalovirus, can cause extensive damage to ependymal cells, resulting in distinct viral inclusions within them. But for most CNS injuries, their direct response is rather limited.
So it's really clear the CNS isn't just one type of cell working in isolation. Each has a specific, unique role and a very distinct way of reacting to injury. What's the big takeaway from all this cellular detail for our understanding of CNS disease?
The profound insight here is that the nervous system's cellular components, neurons, astrocytes, microglia, oligodendrocytes, and ependymal cells, each respond to injury in such a distinctive way that these specific patterns of cellular change visible under a microscope can often point us directly to the type of disease or the underlying mechanism of injury. It's like a cellular fingerprint for CNS pathology. For instance, spotting red neurons immediately signals acute oxygen deprivation, while widespread gliosis hints at sustained chronic damage. This microscopic detective work is fundamental to understanding what truly went wrong in the brain. It's core to neuropathology.
Okay, moving beyond individual cells. The brain is encased in this rigid, unforgiving skull. What happens when pressure starts building up inside that confined space? That seems critical.
This is a critically important area, yes, because increased intracranial pressure, or ICP, can have devastating and very rapid consequences, ranging from subtle neurological changes to immediate death. This pressure can rise from three main scenarios: generalized brain swelling, which we call edema, an increase in the volume of cerebrospinal fluid, or CSF, or a focal mass lesion like a tumor or hemorrhage taking up too much space.
Is brain swelling edema just like swelling anywhere else in the body? I mean, you sprain your ankle, it swells up, but that's usually not, immediately life-threatening.
That's a great question. And no, it's really not quite the same. While it's still an increase in fluid within the brain tissue, the rigid confined space of the skull makes it uniquely dangerous. Unlike your ankle, the brain has nowhere to expand, so any increase in volume directly translates to an increase in pressure. There are two main types of cerebral edema, or brain swelling. First, vesicogenic edema is an increase in extracellular fluid, meaning fluid outside the cells. This happens when the blood-brain barrier, the brain's protective gatekeeper, gets disrupted, allowing fluid and proteins to leak out of the blood vessels and into the intercellular spaces of the brain. The brain famously lacks a lymphatic system, which in other parts of the body would help drain this excess fluid. This absence severely impairs the resorption of that leaked fluid, making it particularly problematic. Vasogenic edema can be localized, perhaps around an infection or a tumor, or it can be generalized, as we might see after a widespread lack of blood flow to the brain.
The second type is cytotoxic edema, which is an increase in intracellular fluid, meaning fluid inside the cells. This occurs when there's direct injury to the cell membranes of neurons, glial cells, or the blood vessel lining cells. It's often seen with generalized oxygen or blood supply insults, or metabolic problems that disrupt the cell's ability to maintain its internal fluid balance. In reality, conditions that cause widespread brain swelling often involve elements of both vasogenic and cytotoxic edema. When you look at a brain with generalized edema, the normal folds or gyri appear flattened, the grooves or sulci are narrowed, and the fluid-filled ventricular cavities inside the brain are compressed. As this swelling expands, it creates a dangerous scenario for potential brain herniation.
And hydrocephalus, that term water on the brain, that also sounds like a fluid problem, but how is it different from general edema?
Right. Hydrocephalus is specifically the accumulation of excessive cerebrospinal fluid, or CSF, within the brain's ventricular system. CSF is normally produced by a structure called the choroid plexus, then circulates through the ventricles and around the brain and spinal cord, before being absorbed back into the bloodstream by specialized structures called arachnoid granulations. Most cases of hydrocephalus happen because there's either impaired CSF flow or impaired resorption, though very rarely it can be caused by overproduction, typically from a choroid plexus tumor. The clinical impact of this is significant. The increased CSF volume expands the ventricles, directly elevating intracranial pressure. In infants, before their skull bones have fused, this leads to an abnormal enlargement of the head. But in adults, once the cranial sutures are closed, the ventricles expand without any change in head circumference, leading to a direct and often rapid increase in brain pressure. We broadly categorize hydrocephalus into two types. Non-communicating or obstructive hydrocephalus occurs when there's a blockage within the ventricular system itself, preventing CSF from flowing freely. This could be from a tumor blocking a passage or a narrowing of the aqueduct, a key channel. In this case, only the parts of the ventricular system before the obstruction will dilate. The second type is communicating hydrocephalus. Here, the entire ventricular system enlarges because the CSF flow within the system is open, or communicating, with the space around the brain. The problem isn't a blockage within the ventricles, but either overproduction of CSF or, more commonly, impaired reabsorption, often due to scarring after an infection like meningitis. There's also a distinct term, hydrocephalus ex vacuo, which isn't true hydrocephalus in the sense of too much pressure. It's a compensatory increase in ventricular volume that occurs when there's a significant loss of brain tissue, for example, from severe brain atrophy, like in Alzheimer disease, allowing the ventricles to simply expand into the empty space.
So when the pressure gets too high, the brain can literally be squeezed and shift position. What are the major types of this brain shift or herniation, and what are their devastating effects?
You've hit on a critical point. When intracranial pressure rises sufficiently, brain tissue can be displaced, forced past rigid internal membranes, or through openings in the skull. This is what we call herniation. It usually results from a mass effect, whether from widespread brain swelling or a more focal lesion like a tumor, abscess, or hemorrhage. This elevated pressure can further compress the brain's delicate blood vessels, cutting off blood flow, which in turn causes secondary ischemic injury and further brain swelling, creating a dangerous, vicious cycle. There are three major types of herniation. First, subfalcine or cingulate herniation. This happens when one side of the brain swells, pushing the lowest part of the cerebral hemisphere, the cingulate gyrus, underneath the falx cerebri, which is a tough, sickle-shaped membrane that separates the two brain halves. This can compress an important artery, leading to a secondary stroke in that area. Second, and often more devastating, is transtentorial, or uncal herniation. This occurs when the innermost part of the temporal lobe, called the uncus, is squeezed against the rigid edge of the tentorium cerebelli, a shelf-like membrane separating the cerebrum from the cerebellum. As this happens, it can compress the third cranial nerve, causing the pupil on that side to dilate and the eye movements to become impaired. It can also pinch off the posterior cerebral artery, leading to a stroke in the brain's visual processing center. In very severe cases, it can even push the brainstem against the opposite side of the skull, paradoxically causing weakness on the same side of the body as the herniation. This type of herniation is often accompanied by tiny, linear hemorrhages deep within the midbrain and pons, called Dure hemorrhages, which result from the distortion and tearing of small, delicate blood vessels. The third and most immediately life-threatening type is tonsillar herniation. Here, the cerebellar tonsils, which are the lowest parts of the cerebellum, are forced downward through the foramen magnum, the large opening at the base of the skull where the spinal cord connects. This is so dangerous because it directly compresses the brainstem, specifically the medulla, which houses the vital centers controlling breathing and heart rate. This can lead to immediate respiratory and cardiac arrest and death.
So whether it's fluid buildup, general brain swelling, or a growing mass, the rigid skull can turn these problems into life or death situations incredibly quickly.
Absolutely. The critical takeaway here is that any increase in intracranial volume, regardless of whether it's from excessive CSF, generalized brain swelling, a hemorrhage, or tumor, directly raises the pressure inside the skull. If this pressure isn't relieved, it inevitably leads to brain herniation, which further compromises blood flow and causes secondary injury and cell death in the affected areas. The chain of events is severe and often fatal, making prompt recognition and intervention paramount.
Okay, shifting gears now. Moving from immediate injury to development, what happens when the brain's fundamental blueprint goes awry during its very formation?
Right. CNS malformations are a fascinating and, unfortunately, often devastating group of conditions. Their origins are complex, frequently involving an interplay of both genetic and environmental influences. Modern genomic sequencing is constantly revealing new genetic variants that cause these malformations. Beyond genetics, we also know that certain toxic compounds and infectious agents, if a fetus is exposed during critical developmental windows, can act as teratogens and directly cause brain malformations. The most common type of CNS malformation are the neural tube defects, which are midline defects that involve some combination of the neural tissue itself, the protective meninges, and the overlying bone or soft tissue. There are two main ways these defects occur. One is a primary failure of the neural tube to close properly during early embryonic development. This then leads to secondary problems in the development of the surrounding bone and soft tissue. Examples include anencephaly, where much of the brain and skull are missing, and myola meningocele, a severe spinal cord defect.
The second way involves primary defects in the development of the axial mesoderm, which is the embryonic tissue that forms the backbone and skull. These bony defects then secondarily affect the CNS. This category includes conditions like encephalopathies, where brain tissue protrudes through a skull defect, and spina bifida. From a clinical perspective, the frequency of these neural tube defects varies significantly among different ethnic groups. If a family had had one child with a neural tube defect, there's a 4 or 5% chance of recurrence in subsequent pregnancies. A well-established and critically important risk factor is folate deficiency during the first few weeks of gestation. This is why folate supplementation for women of reproductive age is so important, as neural tube closure is usually complete by day 28 of embryonic development, often before a woman even knows she's pregnant. Genetic variations in the enzymes that metabolize folic acid also play a role in susceptibility. While the exact mechanism of how folate deficiency causes these defects isn't fully clear, effects on DNA methylation are suspected. Let's delve into some specific examples of neural tube defects.
Anencephaly is a severe malformation where the anterior part of the neural tube fails to develop, resulting in the absence of most of the brain and skull. The forebrain's development is disrupted very early, leaving only a disorganized remnant of tissue. Myelomeningocele is a serious condition where the spinal cord and its membranes extend out through a defect in the vertebral column, most commonly in the lower back. This leads to varying degrees of motor and sensory deficits in the legs, and issues with bowel and bladder control, plus a high risk of infection. If only the meninges protrude, it's called a meningocele. Encephalopathy involves the protrusion of malformed brain tissue through a midline defect in the skull, usually at the back of the head. Lastly, spinal dysraphism, or spina bifida, is the most common neural tube defect, ranging from a hidden bony defect with no symptoms to severe malformations of the spinal cord.
Okay, so those are neural tube issues. What about problems with the cerebrum itself, like its size or overall structure?
These are anomalies that affect the forebrain, typically involving problems with how neurons are generated and how they migrate to their proper locations during development. Neurons actually migrate along specific pathways from their origin to form the cerebral cortex. Many of these patterns are now linked to specific gene mutations crucial for proper brain development. In terms of volume anomalies, the brain can be abnormally large, a rare condition called megalencephaly. More commonly, it can be abnormally small, termed microencephaly, which usually comes with a small head circumference. Microencephaly is linked to chromosome abnormalities, fetal alcohol syndrome, and even in utero viral infections like HIV-1 or Zika. The underlying problem is thought to be a reduced number of neurons reaching the outer layer of the brain, leading to a simplified pattern of folds. When it comes to the cortical surface complexity, we see conditions like lissencephaly, or smooth brain, where there's a significant reduction in the normal folds of the brain, with extreme cases showing no folds at all. This happens because cell migration is disrupted. Then there's polymicrogyria, characterized by many small, irregular convolutions and shallow grooves. The cortex itself has fewer layers than normal, and this can be caused by localized injury during development or be genetically determined. Another fascinating group are neuronal heterotopias. These are essentially misplaced collections of subcortical neurons found in inappropriate locations, as if they got stuck during their migration journey. For example, some forms, called periventricular nodular heterotopias, are linked to X-linked gene mutations. Another type, subcortical band-like heterotopias, also known as double cortex, involve different X-linked gene mutations. Holoprosencephaly is a spectrum of malformations where the cerebral hemispheres fail to properly separate across the midline. In severe cases, this is associated with dramatic midline facial abnormalities, sometimes even a single eye. Milder forms might involve the absence of olfactory nerves. This can be diagnosed prenatally and is associated with chromosomal abnormalities like trisomy 13 and mutations in the sonic hedgehog signaling pathway. Finally, agenesis of the corpus callosum is a relatively common malformation, where the large bundle of white matter fibers connecting the two cerebral hemispheres is absent. On imaging, this can give the lateral ventricles a bat wing appearance. While sometimes associated with intellectual disability, it can surprisingly also be found in individuals with normal intellect. It can be sporadic or familial, and may occur in isolation or with other brain malformations.
Interesting. And the cerebellum and brainstem, which control balance and vital functions, they have their own specific developmental issues too.
Absolutely. There's a distinct group of malformations that primarily affect these posterior fossa structures, often leading to dramatic changes in their size and shape, and sometimes impacting other brain regions as well. The Arnold-Chiari malformation, specifically Chiari type 2, is a well-known example. It involves a smaller than normal posterior fossa, a misshapen cerebellum, and a downward extension of the cerebellar vermis, the central part of the cerebellum, through the foramen magnum, the opening at the base of the skull. This is almost always associated with hydrocephalus and a myelomeningocele in the lower spine. Other related changes can include displacement of the medulla and narrowing of the aqueduct, which can contribute to the hydrocephalus. A less severe variant is Chiari type I malformation, where just the low-lying cerebellar tonsils extend into the upper spinal canal. This can be asymptomatic or cause symptoms like headaches and balance issues due to impaired CSF flow or brainstem compression. Often, neurosurgery can effectively correct these symptoms. The Dandy-Walker malformation presents differently. Here, there's an enlarged posterior fossa, and the cerebellar vermis is either absent or very rudimentary, replaced by a large midline cyst that is directly connected to the fluid-filled fourth ventricle. This essentially means the fourth ventricle is expanded and lacks its normal roof due to the missing vermis. This malformation is often associated with other developmental problems of the brainstem. Lastly, we have Joubert syndrome and related disorders. These are characterized by an underdeveloped cerebellar vermis, along with what appears as elongated superior cerebellar peduncles and an altered brainstem shape. Together, these features create a distinctive molar tooth sign on brain imaging. This group of malformations has been linked to various gene mutations that affect components of the primary cilium, which are tiny, non-moving projections important in cell signaling.
Okay, these next ones, syringomyelia and hydromyelia, they found like cavities or hollow spaces forming within the spinal cord itself.
That's precisely what they are. Hydromyelia specifically refers to the expansion of the ependymoline central canal of the spinal cord, which is normally a tiny vestigial structure. Syringomyelia, often simply called a syrinx, is the formation of a fluid-filled, cleft-like cavity within the substance of the spinal cord itself, adjacent to the central canal. If this cavity extends upwards into the brainstem, we call it syringobulbia. These cavities are often associated with other conditions, most notably a Chiari malformation, but they can also occur with tumors within the spinal canal or following traumatic injury. When we look at them microscopically, they both show destruction of the surrounding gray and white matter of the spinal cord, and this area is then walled off by dense reactive scar tissue formed by astrocytes, which we've discussed as gliosis. Clinically, these conditions typically manifest in young to middle adulthood, usually in the second or third decade of life. A very distinctive clinical feature of a syrinx is an isolated loss of pain and temperature sensation, particularly in the upper extremities. This specific pattern occurs because the expanding cavity disrupts the nerve fibers that cross the spinal cord to carry pain and temperature signals from one side of the body to the other.
It's incredible how early developmental errors, even seemingly small ones, can have such a profound and lasting impact on a person's life and function. So the earlier these errors happen, the more severe the outcome tends to be.
Absolutely. That's a critical concept. The timing of a malformation during development profoundly dictates its severity and the scope of its impact. Neural tube defects highlight how fundamental processes like the initial closure of the neural tube or the subsequent development of surrounding bone are vital. Cortical development, on the other hand, relies on precisely orchestrated cell proliferation and migration, and any disruption there has widespread effects on higher brain function. And these posterior fossa malformations are a distinct category, each with unique features and associations that significantly alter brain structure and function. It really underscores the delicate precision required for proper brain formation.
Okay, let's move to trauma. When we talk about trauma to the CNS, we often think about the immediate impact, a blow to the head, for example. But what are we really talking about beyond just that initial hit? What's the cascade of damage that follows?
That's an excellent way to frame it. CNS trauma is incredibly complex because the brain has very limited capacity for repair, and the specific location of any injury dictates the clinical consequences. The physical forces from a head injury can cause a range of problems: skull fractures, direct damage to the brain tissue itself, which we call parenchymal injury, and crucially, injury to the blood vessels, leading to hemorrhages. These types of injuries often coexist, and the overall magnitude and distribution of the damage depend on things like the shape of the object involved, the force of impact, and whether the head was moving at the time of injury.
So beyond just a broken bone, what's particularly significant or concerning about skull fractures when it comes to brain injury?
A skull fracture isn't just a simple break. A displaced skull fracture, for example, means the bone has been driven into the cranial cavity, which can directly injure the brain. The thickness of the skull bone varies, so its resistance to fracture changes with location. The pattern of a fall can also influence where impacts occur. We often see impacts to the back of the head in falls where someone is awake, while falls from losing consciousness might cause impacts to the front or back. If you see symptoms like problems with lower cranial nerves or bruising around the eyes or behind the ear, even far from the impact site, it strongly suggests a basal skull fracture, a fracture at the base of the skull. Critical complications of these basal fractures include leakage of cerebrospinal fluid from the nose or ear, which then creates an open pathway for infection, significantly increasing the risk of meningitis.
Let's talk about injuries to the brain tissue itself, the perimeningeal injuries. What are the different types we see there?
These range in severity from a mild concussion to severe contusions and lacerations, and they vary depending on the nature and intensity of the trauma. Concussion is a clinical syndrome where there's an altered state of consciousness following a head injury, typically from a sudden change in head momentum, like hitting your head against a rigid object. The hallmark is a sudden temporary neurological dysfunction, a brief loss of consciousness, temporary interruption of breathing, or loss of reflexes. While full neurological recovery is usually expected, patients often have amnesia for the event itself. The exact mechanism isn't fully understood, but it likely involves a temporary disruption of the brainstem's alerting system. What's gaining increasing recognition and concern are the neuropsychiatric syndromes that can develop after repeated concussions, and the accumulating evidence linking these repetitive injuries to a distinct and serious condition called chronic traumatic encephalopathy, or CTE. Then we have direct parenchymal injury, which includes contusions and lacerations. A contusion is essentially a brain bruise resulting from blunt trauma. A laceration, on the other hand, involves the actual tearing of brain tissue, usually by a penetrating object or a sharp bone fragment from a fracture. When the brain surface is hit, the force causes rapid tissue displacement, disrupts blood vessels, and leads to hemorrhage, direct tissue injury, and swelling. This bleeding can extend into the space surrounding the brain. The crests of the brain's folds, the gyrri, are most vulnerable to direct force. Common locations for contusions are areas where the brain meets rough, irregular skull surfaces, such as the frontal lobes near the eye sockets and the temporal lobes. They are less common in areas like the back of the brain or the brainstem, unless there's an adjacent skull fracture.
It's interesting how specific areas are more vulnerable. You hear terms like coup and contre-coup injuries used a lot. What's the difference there?
That's a great question, and it's a key concept in understanding head trauma. A coup injury is a contusion that occurs directly at the point of initial impact. A contre-coup injury, however, is a contusion found on the brain surface diametrically opposite to the point of impact. While they look the same under the microscope, the distinction lies in figuring out where the initial force was applied. If the head is immobile when the trauma occurs, you typically only see a coup injury. But if the head is moving freely, like in a car accident, you can get both coup and/or contracoup lesions, with contracoup often being more severe, as the brain slams against the opposite side of the skull due to sudden deceleration. In extreme cases, like violent hyperextension of the neck, the brainstem can even be torn from the spinal cord, causing instant death. When we examine contusions, they typically have a wedge shape, with the widest part at the impact point. Early on, you'll see swelling and tiny bleeds around capillaries. Within hours, blood spreads throughout the tissue into the brain's outer layers, deeper white matter, and the surrounding fluid space. Neurons show signs of injury within 12 to 24 hours, though functional problems appear much sooner. Damaged axons can swell. The initial inflammatory response brings in a few immune cells, followed by many macrophages, the cleanup crew. Older contusions leave characteristic depressed, yellowish-brown patches on the gyral crests, particularly at contracoup sites. These areas, unfortunately, can sometimes become a source of seizures later on. Another significant type of injury is diffuse axonal injury, or DAI. This involves damage to the brain's deep white matter tracts, the wiring connections, including areas like the cerebral peduncles and the brainstem. Microscopically, you'll see widespread axonal swelling and sometimes small bleeds. Remarkably, up to half of patients who fall into a coma right after trauma, even without any visible brain bruising, have DAI. It's believed that axons are directly injured by the mechanical forces of the trauma, disrupting the flow of essential materials along them. DAI can occur even without a direct skull impact, for example, from rapid angular acceleration, like what happens in blast injuries. In terms of morphology, DAI is characterized by widespread, often asymmetric axonal swellings that develop within hours and can persist for a long time. These are best visualized with special stains that highlight axons or specific proteins. Later, you'll see an increase in microglia, the brain's immune cells, in damaged cortical areas, followed by the degeneration of the affected nerve fiber tracts. More extensive hemorrhagic regions can lead to larger cavities that resemble old strokes. In older contusions, you'll find prominent scarring from astrocytes and macrophages filled with blood pigments.
Injuries to blood vessels seem particularly common with head trauma. How do these typically manifest?
You're right. Traumatic vascular injury is a very frequent and serious complication of head trauma, leading to bleeding in different spaces within the skull. Hemorrhages that occur outside the brain's tissue, but still within the skull, like epidural and subdural hemorrhages, are almost always due to trauma. Though it's worth noting that subdural hematomas can sometimes follow even minor trauma in older individuals with brain shrinkage or those with bleeding disorders. Subarachnoid hemorrhage often accompanies direct brain tissue trauma, but it can also occur spontaneously from an underlying blood vessel anomaly. An epidural hematoma happens when a dural artery, most commonly the middle meningeal artery, is torn. This often occurs with skull fractures, particularly in the temporal region in adults. But in children, their more flexible skulls can allow the vessel to tear even without a fracture. Arterial blood then rapidly leaks out, creating a space between the dura and the skull, compressing the brain. Patients might seem fine initially, experiencing a lucid period before neurological signs suddenly appear. This is a neurosurgical emergency, because fatal brain herniation can occur within mere hours without immediate intervention. A subdural hematoma, on the other hand, results from damage to Bricking veins. These are delicate veins that stretch from the surface of the brain across the fluid-filled subarachnoid space and penetrate the dura to drain into large venous channels. When the brain moves suddenly inside the skull due to trauma, these veins can tear where they pierce the dura. Blood then slowly seeps out and dissects through the layers of the dura, forming the hematoma. Older individuals are especially susceptible because their brains have often shrunk, stretching these bridging veins and making them more fragile. Infants are also vulnerable due to their thin-walled veins. When we look at acute subdural hematomas, they appear as freshly clotted blood on the brain surface, and importantly, they don't extend into the grooves of the brain. The underlying brain tissue often appears flattened due to the compression. This venous bleeding is usually self-limited, and the hematoma gradually breaks down and organizes over time. The clot begins to dissolve within about a week, and then fibroblasts, scar-forming cells, grow in from the dura. Within 1 to 3 months, organized connective tissue forms, firmly attaching the hematoma to the dura. Eventually, the lesion can retract to a thin layer of reactive connective tissue. However, it's not uncommon for chronic subdural hematomas to result from multiple recurrent bleeding episodes from the newly formed thin-walled vessels within this organizing tissue. Clinically, most symptomatic subdural hematomas become apparent within 48 hours of injury. They're most common over the lateral surfaces of the brain and can be bilateral in about 10% of cases. Neurologic signs arise from the pressure on the brain, presenting as focal weakness or sensation changes, or more general symptoms like headache and confusion. A slowly progressive neurological deterioration is typical, though acute worsening can occur. Treatment often involves surgical removal of the blood. The risk of rebleeding is highest in the first few months after the initial hemorrhage.
So beyond the immediate injury and these acute bleeds, what are the lasting long-term consequences of brain trauma? This seems like a really important area now.
That's a critical question, yes. And it's an area that has garnered significant attention recently. A wide range of neurological syndromes can emerge months or even years after a brain injury, profoundly impacting an individual's life. For instance, post-traumatic hydrocephalus can develop, primarily because bleeding into the subarachnoid space from the trauma can obstruct the normal reabsorption of cerebrospinal fluid. Perhaps most discussed now is chronic traumatic encephalopathy, or CTE. This is a specific type of dementia that develops after repeated head trauma. Brains affected by CTE show widespread shrinkage in large fluid-filled ventricles. Microscopically, the hallmark is the accumulation of tau-containing neurofibrillary tangles, but in a very characteristic pattern, often deep in the folds of the brain and around blood vessels, particularly in the frontal and temporal lobes. While a history of concussions is a clear precursor, the precise factors that determine who develops CTE, like the exact number, frequency, or severity of the individual traumatic events, are still uncertain and actively being researched. Beyond these, other significant long-term consequences of brain trauma include post-traumatic epilepsy, an increased susceptibility to infections, and various psychiatric disorders.
And what about the spinal cord? How is it typically affected by trauma?
The spinal cord is exceptionally vulnerable to trauma, primarily because of its rigid bony encasement. Most injuries that damage the cord involve either a transient or permanent displacement of the vertebral column itself. The specific level of the cord injury is absolutely critical in determining the extent of neurological deficits. For example, lesions in the thoracic spine or below can cause paraplegia, affecting the legs, while cervical spine lesions in the neck region typically result in quadriplegia, impacting all four limbs. If the injury is above the fourth cervical vertebra, it can also lead to life-threatening respiratory compromise due to paralysis of the diaphragm. The main cause of these neurological deficits is direct damage at the impact site to both the descending motor tracts and the ascending sensory tracts, effectively isolating the lower spinal cord from the brain, combined with localized damage to the gray matter at that level. Microscopically, the features of traumatic spinal cord injury are very similar to what we see in other parts of the CNS. In the acute phase, at the level of injury, there's hemorrhage, tissue death, and swelling of the axons and the surrounding white matter. The damage typically tapers off above and below the direct injury. In chronic stages, the central areas of neuronal destruction become cystic and galactic, meaning they're filled with fluid and surrounded by dense scar tissue. And in the parts of the cord both above and below the lesion, you'll see evidence of secondary Wallerian degeneration, where the long white matter tracts that were disconnected from their cell bodies begin to break down.
So trauma isn't just about the initial hit. It's truly a complex cascade of cellular and structural damage with profound and lasting repercussions on the brain and spinal cord.
Precisely. The key takeaways here are that physical impact can cause both direct damage at the site, known as a coup injury, and damage on the opposite side, a contra-coup injury. Parenchymal injury isn't just bruising. It also involves widespread diffuse axonal injury, which can be devastating. Vessel tearing leads to critical emergencies like epidural or subdural hematomas. And critically, all of these events can have profound long-term consequences, like chronic traumatic encephalopathy, highlighting the complex and persistent nature of traumatic brain injury.
Now let's shift to problems with blood flow, which are tragically a leading cause of death and disability worldwide. We're talking about strokes, right?
Exactly. Cerebrovascular disease, or stroke as it's clinically termed, refers to brain injury that directly results from altered blood flow. This alteration can take two primary forms. It can be ischemic, meaning an impaired or insufficient blood supply, or it can be hemorrhagic, which involves the rupture of a blood vessel leading to bleeding within or around the brain. Stroke is a devastating condition, ranking among the top causes of death and the most prevalent cause of long-term neurological disability. When we define a stroke, we mean neurological signs and symptoms that appear acutely and persist beyond 24 hours. If those symptoms resolve within that 24-hour window, we usually call it a transient ischemic attack, or TIA, which is still a very important warning sign.
The brain is incredibly sensitive to its oxygen supply. It sounds like even a brief interruption can be absolutely catastrophic.
It truly is. While the brain makes up only about 1–2% of our body weight, it demands a disproportionately high amount of resources. Roughly 15% of the heart's total output and 20% of the body's entire oxygen consumption. This is because it relies strictly on aerobic metabolism to generate the constant energy it needs. So, deprivation of oxygen can occur either from hypoxemia, which is low oxygen content in the blood, or ischemia, meaning inadequate blood flow, which itself can be due to reduced perfusion pressure, like in a state of shock or an actual blockage in a blood vessel. Normally, the brain has a clever mechanism called autoregulation that keeps its blood flow relatively constant even with changes in overall blood pressure. Beyond the general biochemical changes seen with oxygen deprivation in any tissue, CNS ischemia has a unique and destructive pathway called excitotoxicity. This involves the inappropriate and excessive release of excitatory neurotransmitters, primarily glutamate. This glutamate then causes an uncontrolled influx of calcium ions into neurons, particularly through specific receptors, leading to severe neuronal damage and eventual death. It's like the neuron is being overstimulated to death.
What's also a critical concept is the penumbra. This is an at-risk region of brain tissue located around the core area of irreversible damage. In many experimental models, this penumbra can be rescued from cell death with various interventions, suggesting that neurons in this zone can die by a more programmed process like apoptosis in addition to direct necrosis. This is why rapid treatment in stroke is so crucial.
So what specifically happens when blood flow is cut off to just one part of the brain, leading to a focal stroke? How does that unfold?
This is what we call focal cerebral ischemia, where there's a reduction or complete cessation of blood flow to a specific localized area of the brain. This is usually caused by a partial or complete obstruction of an artery. If this lack of blood flow is sustained, it leads to an infarction, meaning tissue death, in the territory supplied by that compromised vessel. The size, exact location, and shape of this dead tissue, as well as the extent of overall damage, are highly influenced by how long the ischemia lasts, and crucially, how adequate the collateral blood flow is. The main source of this collateral flow is the circle of Willis, a network of arteries at the base of the brain, supplemented by smaller connections. However, the deep penetrating vessels, those tiny arteries supplying structures like the thalamus and basal ganglia, have very little collateral flow, making them extremely vulnerable. The causes of occlusive vascular disease that lead to these cerebral infarctions fall into a few main categories: embolism, in situ thrombosis, or various forms of vasculitis. Embolism is actually the most common cause of vascular occlusion in the brain. Here, a blood clot or other material travels from somewhere else in the body and lodges in a brain artery. The most frequent culprits are blood clots from the heart, often originating from a heart attack, valvular disease, or an irregular heartbeat like atrial fibrillation. Clots can also break off from atherosclerotic plaques, especially in the carotid arteries in the neck. Rarer sources include paradoxical emboli, or even fat or air emboli. The middle cerebral artery, a direct extension of the internal carotid, is most frequently affected by these emboli, as they tend to lodge at vessel branch points or pre-existing narrowed areas. Sometimes, multiple tiny emboli, like from fat after a major bone fracture, can cause what's called shower embolization, leading to widespread brain dysfunction without clear focal signs. Thrombotic occlusion refers to a blood clot forming directly within a cerebral artery. This is most commonly caused by acute changes in vulnerable atherosclerotic plaques, much like what happens in coronary artery disease causing a heart attack. Common sites for these clots include the carotid bifurcation in the neck, the origin of the middle cerebral artery, and at either end of the basilar artery in the brainstem. These clots cause progressive narrowing of the vessel, can extend forward, or even fragment and send smaller emboli further downstream. Atherosclerotic cerebrovascular disease is very frequently associated with systemic conditions like high blood pressure and diabetes. Inflammatory processes, or vasculitides, involving blood vessels can also lead to narrowing or complete occlusion, and thus brain infarcts. This can be due to infectious agents like syphilis or tuberculosis, which are more common now in immunosuppressed individuals, or non-infectious inflammatory conditions. In some cases, a condition called primary meningitis of the CNS can develop, where the inflammation is confined to the brain's blood vessels without evidence of systemic vasculitis.
So, once the blood flow is cut off and an infarct develops, what does the resulting brain damage actually look like and how does it change over time?
Right. Brain infarcts are broadly categorized into non-hemorrhagic, or pale infarcts, and hemorrhagic ones. They usually start as non-hemorrhagic infarcts because the brain's blood supply is largely an end organ circulation, meaning there's limited collateral flow. However, secondary hemorrhagic transformation can occur, particularly if blood flow is restored after a period of ischemia, whether spontaneously or through therapeutic interventions like clot-busting drugs. This reperfusion injury can cause anything from tiny pinpoint bleeds to larger confluent hemorrhages. This distinction is critically important because, for example, clot-busting therapy is generally not given if a stroke is already hemorrhagic. The appearance of a non-hemorrhagic infarct changes dramatically over time. Grossly, meaning to the naked eye, there's very little change in the first 6 hours. But within 48 hours, the tissue becomes pale, soft, and swollen, and the normal distinction between gray and white matter becomes blurry. From 2 to 10 days, the brain tissue becomes gelatinous and fragile, and its boundaries become clearer as the swelling starts to resolve. Then from 10 days to 3 weeks, the tissue begins to liquefy, eventually forming a fluid-filled cavity. Under the microscope, the evolution is a fascinating process. In the acute phase, within 6 to 12 hours, neurons show eosinophilic necrosis, those dead red neurons we talked about. There's also swelling inside and outside the cells, and the normal staining characteristics of the tissue are lost. Neutrophil immune cells start arriving, peaking around 48 hours. In the subacute phase, from 24 hours to about 2 weeks, tissue necrosis becomes prominent, and there's a massive influx of specialized cleanup cells called foamy macrophages, which become the dominant cell type, filled with breakdown products of myelin and blood. At the edges, reactive astrocytes begin to appear, forming new blood vessels. Finally, in the healed phase, after several months, the astrocyte response subsides, leaving behind a dense meshwork of glial scar tissue, new capillaries, and connective tissue. In the cortex, the damaged area is now a fluid-filled cavity, separated from the surrounding membranes by scar tissue. Hemorrhagic infarcts follow a similar progression, just with the added element of blood extravasation and reabsorption. Venous infarcts, from blockages in the brain's veins, are often hemorrhagic.
What about those really tiny, deep infarcts you sometimes hear about, the lacunar ones? What causes those specifically?
Yes, lacunar infarcts are a very distinct type. They occur when chronic high blood pressure or hypertension damages the tiny, deep penetrating arteries and arterioles that supply structures like the basal ganglia, the deep white matter, and the brainstem. This high blood pressure causes a specific hardening and thickening of these small vessels, a condition called arteriolosclerosis. If this progresses to a point where the vessel becomes completely clotted or occluded, it results in a small, cavitated infarct, a lacoon. These are arbitrarily defined as less than 15 millimeters wide and can be single or multiple. They're very common in specific deep brain regions. Microscopically, you just see a small area of tissue loss surrounded by scar tissue. Depending on their location, these tiny infarcts can be completely silent or, if in a critical area, cause significant impairment. Sometimes these affected vessels just show widened spaces around them without actual infarction, a condition known as état criblé.
Okay, so that's focal problems. What about when oxygen supply is compromised to the entire brain, not just one specific area?
That's global cerebral hypoxia-ischemia. This occurs from a widespread reduction of blood flow to the entire brain, such as during cardiac arrest, shock, or very severe low blood pressure, or from a severe decrease in the blood's ability to carry oxygen, like in carbon monoxide poisoning. The outcome varies greatly depending on how severe and how long the insult lasts. Mild cases might only cause a temporary period of confusion with the full recovery. However, severe and prolonged global insults can lead to irreversible, widespread CNS damage, known as diffuse hypoxia ischemic encephalopathy, with extensive neuronal death. Tragically, patients who survive such severe events may enter a persistent vegetative state or be declared brain dead, meaning irreversible injury to both the outer brain and the brainstem, with no reflexes or spontaneous breathing. If kept alive on mechanical ventilation, the brain can literally undergo widespread liquefaction, a state sometimes called respirator brain. A critical concept here is selective vulnerability. Neurons are generally the most sensitive cells in the CNS to a lack of oxygen, but glial cells also suffer. What's fascinating is that certain groups of neurons are exquisitely vulnerable. Specifically, the pyramidal neurons in a particular area of the hippocampus called CA1, also known as summer sector, the delicate Purkinje cells in the cerebellum, and the pyramidal neurons in certain layers of the cerebral cortex. The precise molecular reasons for this selective vulnerability are still being actively researched. When we look at a brain affected by global ischemia, it appears swollen and edematous, with flattened folds and narrowed grooves. Microscopically, the changes evolve over time, mirroring those seen in focal strokes, but they are widespread throughout the brain. Those dead red neurons appear early, and a peculiar pseudolaminar necrosis can occur in the cortex, where certain layers of neurons are selectively destroyed while others are preserved. We also often see watershed infarcts, which occur in the regions at the very ends of the arterial blood supply, furthest from the main vessels, particularly after severe drops in blood pressure.
Okay, so beyond blockages causing ischemia, bleeding is the other major type of stroke. Where does this bleeding typically happen, and what's usually the underlying cause?
That's right. Hemorrhage or bleeding can occur anywhere within the skull, either outside or directly inside the brain tissue itself. While epidural and subdural hemorrhages are typically traumatic, intraparenchymal and subarachnoid hemorrhages are more often manifestations of underlying cerebrovascular disease, meaning problems with the brain's blood vessels. Intraparenchymal hemorrhage refers to the rupture of a small blood vessel directly within the brain tissue, leading to bleeding there. This is different from a hemorrhagic transformation of an ischemic stroke. These spontaneous, non-traumatic hemorrhages are most common in middle to late adulthood, peaking around age 60. We broadly categorize them as ganglionic hemorrhages if they occur deep in the brain, like in the basal ganglia or thalamus, or lobar hemorrhages if they occur in the cerebral lobes. The two major causes of these are hypertension, or chronic high blood pressure, and cerebral amyloid angiopathy, or CAA. Other less common factors can include bleeding disorders, tumors, or vascular malformations. Hypertension is by far the most common risk factor for deep brain hemorrhages, accounting for over 50% of significant bleeds. Chronic high blood pressure leads to profound abnormalities in blood vessel walls. It accelerates hardening of larger arteries and causes a specific thickening and hardening of smaller arteries. These vessels, though thickened, become more fragile and vulnerable to rupture. If they rupture, you get a hemorrhage. If they just become occluded, you get a lacunar infarct. Cerebral amyloid angiopathy, or CAA, is the most common risk factor for lobar hemorrhages, those that occur in the outer cerebral lobes. In CAA, abnormal proteins called amyloid peptides, similar to those found in Alzheimer's disease, are deposited in the walls of medium and small blood vessels in the meninges and cerebral cortex. These amyloid-laden vessels become rigid and fragile, prone to rupture, leading to hemorrhage. Many people with CAA also show evidence of numerous tiny microbleeds on brain imaging. Genetic factors like specific variations in the ApoE gene can increase the risk of bleeding in CAA. Microscopically, an acute intraparenchymal hemorrhage is a central core of clotted blood that compresses the surrounding brain tissue, causing secondary damage and swelling. As the blood is cleared by macrophages, the area of damage becomes a browner-stained cavity surrounded by scar tissue. Clinically, large hemorrhages can be devastating, especially if they extend into the ventricles. Smaller ones might be silent or mimic a stroke, with gradual improvement as the body clears the blood.
And what about that sudden, dramatic, worst headache ever that everyone associates with a burst aneurysm? What's happening there?
That's the classic sign, yes, of a ruptured saccular aneurysm, which is the most frequent cause of spontaneous subarachnoid hemorrhage, or SAH. While trauma is the most common cause of SAH overall, when it happens spontaneously, it's typically due to these vascular anomalies. Other less common causes include internal brain bleeds rupturing into the ventricles or other types of vascular malformations. A saccular aneurysm, often called a berry aneurysm, is the most common type of intracranial aneurysm. About 90% of them are found at the branching points of major arteries in the anterior circulation, particularly within the circle of Willis, that critical arterial network at the base of the brain. About 20–30% of affected individuals have multiple aneurysms. The precise cause of saccular aneurysms is still not fully understood, but there's a strong belief that they originate from a developmental weakness in the blood vessel wall, specifically a lack of smooth muscle in a particular elastic layer. While most are sporadic, genetic factors are clearly important. They're more common in first-degree relatives and certain genetic disorders. Crucially, predisposing factors like cigarette smoking and high blood pressure are present in about half of affected individuals. These aneurysms are not present at birth, but develop over time at these weakened points in the vessel wall. Morphologically, an unruptured saccular aneurysm looks like a thin-walled outpouching, usually at an arterial branching point, appearing bright red and translucent. They can range from a few millimeters to a few centimeters. Atherosclerotic plaques, calcification, or blood clots can sometimes be found within their walls. When they rupture, which usually happens at the very tip of the sac, blood rapidly spills into the subarachnoid space, or sometimes into the brain itself. Clinically, rupture is most frequent in middle age, slightly more common in women. The overall risk of rupture is low, but it increases significantly with larger aneurysm size. Rupture can happen at any time, but about 1/3 are associated with sudden increases in intracranial pressure, such as from straining or orgasm. Patients are struck by a sudden, excruciating headache, often described as the worst headache of my life, and can rapidly lose consciousness. Tragically, between 25 and 50% die with the first rupture. Survivors often regain consciousness, but rebleeding is a common and unpredictable complication, and each subsequent bleed carries a worse prognosis. Beyond the immediate crisis, subarachnoid hemorrhage has critical consequences. Acutely, within hours to days, there's a high risk of ischemic injury or stroke from vasospasm, where the blood vessels in the area constrict due to chemical mediators released from the extravasated blood. Later, during the healing phase, scarring and fibrosis of the meninges can occur, obstructing the normal flow of CSF and leading to hydrocephalus.
Are there other types of abnormal blood vessel formations in the brain that can cause problems like bleeding?
Yes, there are 4 main types of vascular malformations: arteriovenous malformations, AVMs, cavernous malformations, capillary telangiectasias, and venous angiomas. Of these, AVMs and cavernous malformations are the 2 most clinically significant types, both associated with a risk of hemorrhage and neurological symptoms. While they aren't true tumors, we've recently learned that arteriovenous malformations are often associated with specific genetic mutations in the endothelial cells that line these vessels, suggesting a dysregulated signaling pathway plays a central role in their development. Arteriovenous malformations, AVMs, are the most common clinically significant type. They're found more often in males and typically become symptomatic between 10 and 30 years of age, often presenting with seizures, bleeding within the brain, or subarachnoid hemorrhage. The most common site for an AVM is in the territory of the middle cerebral artery. In newborns, very large AVMs can cause heart failure due to the high volume of blood shunting directly from arteries to veins. Morphologically, AVMs are tangled networks of worm-like vascular channels. These channels have high blood flow because arterial blood shunts directly into veins without the usual capillary bed in between. They can involve the subarachnoid space, the brain tissue, or both. They're composed of greatly enlarged abnormal blood vessels, separated by scar tissue, often with evidence of previous bleeding. Some of these vessels will show features of arteries, and others will look more venous. Cavernous malformations are different. They consist of distended, loosely organized vascular channels that are arranged directly back to back, with collagenized walls of varying thickness, and crucially, little to no normal brain parenchyma interspersed between the vessels. They're most often found in the cerebellum, pons, and deeper brain regions. These are low-flow channels, meaning there's no high-pressure shunting. They're often surrounded by evidence of old bleeding, tissue damage, and calcification. Familial forms are relatively common and inherited as an autosomal dominant trait, and a hallmark of these familial cases is the presence of multiple such lesions.
It sounds like repeated small strokes, maybe even ones that go unnoticed, can accumulate and eventually lead to a form of dementia. Is that accurate?
Yes, absolutely. Individuals who, over many months or years, suffer multiple small strokes or infarcts in both the gray matter, the cortex, thalamus, and basal ganglia, and the deep white matter, can develop a distinct clinical syndrome known as vascular dementia. This form of dementia is characterized not just by cognitive decline, but often by gait abnormalities, pseudobulbar signs, problems with speech and swallowing, and frequently superimposed focal neurological deficits like weakness or numbness in a specific area. Vascular dementia is caused by various types of widespread vascular disease. These include general hardening of the arteries in the brain, blood clots forming in or traveling to brain vessels, and the specific hardening of small arteries that results from chronic hypertension. When the damage specifically and preferentially affects large areas of the subcortical white matter, leading to myelin and axon loss, it's given the specific name Binswanger disease, or subcortical white matter dementia. This condition needs to be carefully distinguished from other diseases affecting the white matter. It's also very common for individuals with primary neurodegenerative diseases, like Alzheimer's, to also have evidence of cerebrovascular disease. The presence of significant vascular disease increases the risk of neurological impairment for a given level of degenerative changes, suggesting it acts as an independent factor disrupting normal brain function.
This whole section really highlights how deeply intertwined the brain's function is with its blood supply. Disruption, whether from a blockage or bleeding, can lead to everything from these sudden acute crises to a slow, chronic decline over years.
That's the core essence of it, absolutely. Stroke is the clinical term for acute neurological deficits resulting from either vessel occlusion or rupture. Cerebral infarction, the ultimate consequence of ischemia, can be focal, widespread, or confined to specific boundary zones. Primary intraparenchymal hemorrhages are often strongly linked to chronic high blood pressure or to cerebral amyloid angiopathy. And importantly, spontaneous subarachnoid hemorrhage typically points to an underlying structural vascular anomaly, most commonly an aneurysm, or sometimes an arteriovenous malformation. Understanding these distinct pathways of vascular injury is fundamental to diagnosis and treatment.
Okay, let's move on to infections. The brain has its own remarkable defenses, like the blood-brain barrier, but pathogens, those disease-causing microbes, can find ways to get in. What are the common routes of infection to the central nervous system?
It's true, the CNS has unique protective barriers, but microbes are incredibly persistent. Infection can damage neurons and glia directly or indirectly through the toxins they produce, the destructive inflammatory response they trigger, or even through the body's own immune mechanisms. There are four principal ways microbes typically gain access to the nervous system. First, and most common, is hematogenous spread, meaning through the bloodstream. Infectious agents usually enter via the arterial circulation, but they can also spread backward through veins, especially from the face. Second, direct implantation of microorganisms often happens traumatically, like from a penetrating injury, but it can also occur in congenital malformations like myelomeningocele, where there's an open pathway. Third, local extension is when an infection spreads from an adjacent infected structure, such as from the sinuses, teeth, skull, or vertebrae. Finally, peripheral nervous system transport is a specialized route where certain viruses like rabies and herpes zoster can actually travel along peripheral nerves to reach the CNS.
Let's break down the major types of CNS infections. Where should we begin?
We'll start with meningitis, which is an inflammatory process primarily affecting the leptomeninges, the delicate membranes covering the brain and spinal cord, and the cerebrospinal fluid within the subarachnoid space. It's usually caused by infection. If the inflammation extends to also involve the brain tissue itself, we call it meningoencephalitis. While infection is the most common cause, meningitis can also be non-bacterial, from a chemical irritant, or even related to systemic autoimmune diseases. For classification, we generally talk about acute pyogenic, meaning bacterial, acute aseptic, which is typically viral, and chronic forms like tuberculous or fungal meningitis. Each of these has a characteristic set of changes in the CSF that helps us diagnose them.
Let's dive into acute pyogenic bacterial meningitis first. What are the common culprits, and how does it usually present clinically?
The bacteria responsible for acute pyogenic meningitis actually vary quite a bit depending on a person's age. For neonates, Escherichia coli and group B streptococcus are common. In adolescents and young adults, Neisseria meningitatis is prevalent. For the elderly, we often see Streptococcus pneumonia and Listeria monocytogenes. Thanks to widespread immunization, the incidence of Haemophilus influenza has significantly decreased. Clinically, patients present with general signs of infection fever, malaise superimposed on very specific symptoms of meningeal irritation and neurological impairment. These include a severe headache, sensitivity to light, irritability, confusion, and a stiff neck. A lumbar puncture or spinal tap is diagnostic, revealing cloudy or frankly purulent cerebrospinal fluid with a very high white blood cell count, predominantly neutrophils, increased CSF pressure, elevated protein, and importantly, markedly reduced glucose. If left untreated, bacterial meningitis is almost uniformly fatal, but antibiotics have dramatically reduced mortality. A feared complication, especially with meningococcal and pneumococcal meningitis, is Waterhouse-Friderichsen syndrome, a severe septicemia with hemorrhagic adrenal damage. In immunosuppressed individuals, more unusual bacteria might cause meningitis, often with an atypical course. Morphologically, you see a thick, pus-like exudate within the leptomeninges spread over the brain surface. The blood vessels and the meninges are engorged. The distribution of this pus can vary. For instance, in H. influenza, it's often at the base of the brain, while with pneumococcal, it's densest over the top of the brain. The pus can track along the surface blood vessels. In severe, rapidly progressing cases, the inflammation can even extend into the ventricles, causing ventriculitis. Microscopically, the subarachnoid space is packed with neutrophils, especially around blood vessels. We might see bacteria on a Gram stain. In fulminant cases, inflammatory cells can infiltrate veins, extending into the brain and causing secondary vasculitis and clots, which can lead to hemorrhagic strokes. A significant long-term consequence is leptomeningeal fibrosis, where the meninges scar and thicken, which can obstruct CSF flow and lead to hydrocephalus.
Okay, then aseptic meningitis implies no bacterial growth on standard cultures, so it's typically viral, right? What's the difference in how it looks and presents?
That's exactly right. Acute aseptic, or viral meningitis, is a clinical term for meningitis symptoms when bacterial cultures come back negative. While viruses are the usual culprits, it can also be caused by certain bacteria that don't grow on standard cultures, rickettsia, or even autoimmune conditions. The clinical course is generally less severe and less rapid than bacterial meningitis. The CSF findings are distinct. You'll see a lymphocytic pleocytosis, meaning an increase in lymphocytes rather than neutrophils, only moderately elevated protein, and almost always normal glucose levels. Viral aseptic meningitis is typically self-limited, and treatment focuses on managing symptoms. Although new detection techniques are changing this, the specific viral agent is often not identified, though enteroviruses are the most common cause. Sometimes a chemical meningitis can mimic this, as seen with the rupture of a benign cyst into the subarachnoid space, causing a sterile inflammatory response.
So those are the widespread infections affecting the meninges. What about acute, localized, pus-forming infections in the brain or the spaces around it?
Yes, these are acute focal suppurative infections, meaning they form localized collections of pus and are typically bacterial or fungal. They can occur within the brain tissue itself or in the spaces just beneath or above the dura, the outermost brain membrane. A brain abscess is a localized area of dead brain tissue surrounded by inflammation, almost always caused by bacteria. They can start from direct introduction of organisms, like a penetrating head injury, or from local extension from nearby infections, such as a mastoid infection behind the ear or a sinus infection. Most commonly, they spread hematogenously, meaning the bacteria travel through the bloodstream from a primary infection site elsewhere in the body, such as the heart, lungs, bones, or even from a dental infection. Certain predisposing conditions increase the risk, including acute bacterial endocarditis, congenital heart disease with shunts, chronic lung infections, and very importantly, systemic immunosuppression. Common causative bacteria in otherwise healthy individuals include streptococci and encephalopathies.
Morphologically, a brain abscess is a distinct lesion with a central area of liquefied necrotic brain tissue, surrounded by considerable swelling. At its outer edge, there's a lot of highly vascular granulation tissue, which acts as a barrier, but whose vessels are abnormally leaky, contributing to significant swelling in the surrounding brain. Established abscesses develop a tough, collagenous capsule formed by fibroblasts. Outside this capsule, there's a zone of reactive gliosis, with prominent swollen astrocytes. Clinically, cerebral abscesses are very destructive. Patients typically present with progressive focal neurological deficits, like weakness on one side, and signs of increased intracranial pressure. The CSF usually shows a high white cell count, increased protein, and normal glucose. The source of the infection might be far removed, making diagnosis challenging. Complications include fatal brain herniation, rupture of the abscess into the ventricles causing widespread inflammation, and blood clots in the brain's veins. Thankfully, with modern surgery and antibiotics, the high mortality rate has significantly dropped to less than 10%.
A subdural empyema occurs when bacterial or rarely fungal infections spread from the skull bones or paranasal sinuses into the subdural space, the potential space between the dura and the arachnoid membrane. The delicate arachnoid and the space beneath it are usually unaffected. A large empyema can create a mass effect, compressing the brain, and can also lead to blood clots in the bridging veins, which in turn can cause a stroke. Symptoms include fever, headache, neck stiffness, along with symptoms from the primary infection source. CSF findings are similar to a brain abscess. If left untreated, it leads to focal neurological signs, lethargy, and coma. But with prompt diagnosis and surgical drainage, full recovery is possible, though a thickened dura can be a long-term consequence. An extradural abscess, which forms outside the dura, is commonly associated with bone infections, often arising from adjacent sinusitis or following surgery. In the spinal epidural space, these can rapidly compress the spinal cord, constituting a neurosurgical emergency.
So some bacterial infections don't just cause these acute, immediate problems. They can lead to chronic, smoldering issues in the brain and its membranes, too.
That's correct. Certain bacterial infections, if they get into the CNS, can establish chronic, long-lasting inflammatory processes. The most notable culprits here are Mycobacterium tuberculosis, the cause of tuberculosis, Treponema pallidum, the bacterium responsible for syphilis, and Borrelia species, which cause Lyme disease. Let's consider tuberculosis. CNS involvement can occur as part of active systemic tuberculosis or appear in isolation, often from the seeding of silent infections elsewhere in the body, typically the lungs. Morphologically, the most common pattern is a diffuse meningoencephalitis. Here, the subarachnoid space, particularly at the base of the brain, becomes filled with a thick, gelatinous or fibrinous exudate, which can effectively encase and compress the cranial nerves. You might also see discrete white areas of inflammation scattered over the membranes. Microscopically, this involves a mixed inflammatory infiltrate, including lymphocytes, plasma cells, and macrophages. In more severe cases, well-formed granulomas with central cheesy necrosis and giant cells are seen.
The arteries in the subarachnoid space can also be affected by obliterative endarteritis, a thickening of the vessel walls that can narrow their lumen. Acid-fast stains can reveal the organisms. The infection can spread to the ventricles via the CSF. A significant long-term consequence is dense, fibrous scarring of the arachnoid membranes, especially at the base of the brain, which can lead to hydrocephalus. Tuberculosis can also form one or more well-circumscribed masses within the brain tissue itself, called tuberculomas, which can mimic brain tumors. Clinically, patients often present with headache, malaise, confusion, and vomiting. The CSF typically shows a mononuclear cell increase, strikingly elevated protein, and moderately reduced or normal glucose. Complications include hydrocephalus due to scarring and arterial occlusion leading to strokes. In AIDS patients, CNS tuberculosis is pathologically similar, but may show a less robust host inflammatory reaction. Then we have neurosyphilis, which is a manifestation of tertiary syphilis occurring in about 10% of untreated infections. HIV infection is known to increase the risk and accelerate the progression of neurosyphilis. Neurosyphilis can manifest in several patterns. Meningovascular neurosyphilis involves chronic inflammation of the meninges, often with associated thickening and inflammation of blood vessel walls, which can lead to strokes. Cerebral gummas, distinct mass lesions rich in plasma cells, can also form. Paretic neurosyphilis is caused by the direct invasion of the brain by the spirochete. This leads to insidious progressive cognitive impairment, changes in mood including delusions of grandeur, and ultimately severe dementia. Microscopically, there's neuronal loss, proliferation of microglia, and scarring, with iron deposits from tiny bleeds. T-base dorsalis is a different pattern, involving damage to sensory nerve fibers in the dorsal roots of the spinal cord. This causes impaired sensation of joint position, leading to an unsteady gait, loss of pain sensation, and absent deep tendon reflexes. Lastly, neuroborreliosis, or Lyme disease, is caused by Borrelia burgdorferi, transmitted by ticks. It can cause highly variable neurological symptoms, including aseptic meningitis, facial nerve palsies, and a broader encephalopathy.
Okay, moving to viruses. They seem to cause inflammation in both the meninges and the brain tissue itself, rather than just one or the other, like some bacteria.
You're right, they often do. Viral encephalitis refers to an infection primarily of the brain tissue, or parenchyma, and it's almost always accompanied by inflammation of the meninges, which is why it's often called meningoencephalitis. If the spinal cord is also involved, it's called encephalomyelitis. Some viruses have a particular neural tropism, meaning they preferentially infect specific cell types or regions of the brain. Latency, where the virus remains dormant, is important for some, like herpes zoster. Interestingly, even systemic viral infections without direct CNS penetration can be followed by immune-mediated demyelination. Fetal infections, like rubella or Zika, can cause congenital malformations. And in rare cases, a slowly progressive neurodegenerative syndrome can emerge years after a viral illness. Arthropod-borne viral encephalitis, or arboviral encephalitis, is a major cause of epidemics, particularly in tropical regions, and carries high rates of illness and death. These viruses are transmitted by insect vectors and have animal hosts. Clinically, affected individuals develop generalized neurological deficits like seizures, confusion, stupor, or coma, as well as focal signs such as reflex asymmetry or eye movement problems. West Nile encephalitis, for instance, can involve the spinal cord and cause a polio-like paralysis. The CSF typically shows a clear fluid, slightly elevated pressure, elevated protein, and normal glucose, initially with some neutrophils but rapidly shifting to lymphocytes. Morphologically, these arboviral encephalopathies show similar microscopic changes. There's meningoencephalitis with an accumulation of lymphocytes around blood vessels. You also find multiple small areas of tissue death in both gray and white matter, with individual neurons dying and microglia engulfing their debris. Microglial cells often form small clusters called microglial nodules. In severe cases, there can be inflammation of blood vessels and focal hemorrhages. Herpes simplex virus type 1, HSV1, encephalitis is the most common viral encephalitis. It typically affects children and young adults, and interestingly, most don't have a prior history of cold sores. Initial symptoms often involve changes in mood, memory, and behavior. Antiviral medications are effective and have significantly reduced mortality. The infection primarily affects, and is most severe, in the inferior and medial temporal lobes and the orbital gyri of the frontal lobes, often causing necrotizing and hemorrhagic damage. Microscopically, you'll see inflammation around blood vessels and, characteristically, Cowdery type A intranuclear viral inclusions within both neurons and glial cells. Herpes simplex virus type 2, HSV2, can cause meningitis in adults, but in newborns it can lead to severe encephalitis acquired during vaginal delivery. In individuals with active HIV infection, HSV2 can cause an acute hemorrhagic and necrotizing encephalitis. Varicella-Zoster virus, VZV, the chickenpox virus, usually doesn't involve the nervous system during primary infection. However, it can lie dormant in sensory neurons and reactivate later in life as shingles, causing a painful skin rash. While usually self-limited, some individuals, especially older adults, can develop persistent pain called postherpetic neuralgia. Cytomegalovirus, CMV infection of the nervous system, is typically seen in fetuses and immunosuppressed individuals. In utero infection can cause severe brain destruction, microcephaly, and calcification. In AIDS patients, CMV is a common opportunistic pathogen. Morphologically, it often causes subacute encephalitis, particularly affecting the subendymal regions, leading to severe hemorrhagic and necrotizing inflammation of the ventricles. Any CNS cell type can be infected, showing characteristic enlarged cells with prominent intranuclear and intracytoplasmic inclusions. Poliomyelitis, while largely eradicated in many parts of the world by vaccination, remains a problem in some countries. In non-immunized individuals, the virus can invade the nervous system. Microscopically, acute cases show inflammation around blood vessels and a unique phagocytosis of motor neurons in the spinal cord's interior horns. Long-term survivors show neuronal loss and scarring in these areas. Clinically, it starts with meningeal irritation, potentially progressing to spinal cord involvement, causing flaccid paralysis and muscle wasting. Post-polio syndrome, characterized by progressive weakness and pain, can develop years later. Rabies is a severe encephalitis transmitted by animal bites. The virus travels along peripheral nerves to the CNS. Clinically, it starts with nonspecific symptoms, then progresses to extreme CNS excitability, painful spasms, and the classic hydrophobia, aversion to water. It's almost always fatal. Microscopically, the pathognomonic finding is Negri bodies, which are cytoplasmic, eosinophilic inclusions in specific neurons of the hippocampus and cerebellum. Human immunodeficiency virus, HIV, cause neuropathological changes in a significant majority of AIDS patients before effective antiretroviral therapy. These effects could be direct viral damage, opportunistic infections, or primary CNS lymphoma. Even with treatment, cognitive changes collectively called HIV-associated neurocognitive disorders, or HAND, can persist. Morphologically, HIV encephalitis is characterized by chronic inflammation with widely distributed microglial nodules, often containing multinucleated giant cells. Progressive multifocal leukoencephalopathy, PML, is an encephalitis caused by the JC polyomavirus, almost exclusively in immunosuppressed individuals. It primarily targets oligodendrocytes, leading to demyelination. Clinically, it causes focal, relentlessly progressive neurological symptoms. Morphologically, you see irregular, ill-defined patches of white matter injury with demyelination, lipid-laden macrophages, and importantly, enlarged oligodendrocyte nuclei containing glassy viral inclusions at the lesion edges.
And finally, rounding out infections, fungi can also get into the brain, especially in immunocompromised people. What does that look like pathologically?
Yes, fungal infections of the CNS are primarily a concern in immunocompromised individuals. The brain is usually involved after widespread dissemination through the bloodstream. Common culprits include Candida, Mucor, Aspergillus, and Cryptococcus. Fungal CNS infections typically manifest in three main forms: chronic meningitis, vasculitis, and direct parenchymal invasion. Vasculitis is most common with certain fungi, like Mucor and Aspergillus, which directly invade blood vessel walls, leading to blood clots and often strikingly hemorrhagic strokes. Parenchymal infection can appear as granulomas or abscesses. Candida typically causes multiple small abscesses, while Cryptococcus forms unique aggregates within the perivascular spaces of the brain, often with minimal inflammation. Cryptococcal meningitis is a common opportunistic infection in AIDS patients, ranging from rapid and fatal to a slower indolent course. The CSF may have few cells but high protein, and the distinctive mucoid-encapsulated yeasts can be visualized with special stains. We should also briefly mention other infectious diseases. Protozoa, like those causing malaria and toxoplasmosis, bacteria like rickettsia causing typhus, and even parasitic worms can affect the CNS. Cerebral toxoplasmosis, for example, is a major opportunistic infection in HIV patients, often presenting as multiple ring-enhancing lesions on imaging. Cerebral malaria is the deadly complication of Plasmodium falciparum infection, and cerebral amoebiasis can cause rapidly fatal encephalitis.
Wow, That's a truly vast landscape of infections, isn't it? From tiny bacteria and viruses to fungi and parasites, each seems to leave its own specific, recognizable signature on the CNS.
Indeed. The fundamental insight is that pathogens employ distinct routes to invade the nervous system, and once inside, cause different, identifiable patterns of disease. Bacterial infections can lead to widespread acute meningitis or localized destructive abscesses. Viral infections often show specific preferences for certain brain regions or cell types, and crucially, a patient's immune status profoundly influences both their susceptibility to these infections and how the disease presents clinically. Understanding these distinct characteristics is vital for accurate diagnosis and effective treatment.
Okay, let's switch gears to myelin. We know it's absolutely essential for our nerves to function properly, acting like insulation on an electrical wire. So what happens when this crucial myelin is damaged in the brain? What are demyelinating diseases?
That's a great analogy. Demyelinating diseases are a group of disorders where the primary problem is damage to myelin, while the underlying nerve fibers or axons are relatively preserved, at least initially. The clinical deficits we see in patients, things like weakness, numbness, or vision problems, stem directly from this impaired electrical impulse transmission along the nerves. Unfortunately, the central nervous system has a very limited capacity for myelin regeneration, and over time, if the myelin damage continues, secondary damage to the axons themselves can also occur, leading to more permanent deficits. Myelin loss can result from several different pathological processes. The most well-known involves the body's own immune system mistakenly attacking myelin. This is what happens in conditions like multiple sclerosis. Myelin can also be damaged by certain infections, such as progressive multifocal leukoencephalopathy, and then there are inherited disorders that affect the actual synthesis or turnover of myelin components. These are generally called leukodystrophies, which we often discuss more broadly within the category of metabolic disorders.
So let's talk about the most well-known demyelinating disorder, multiple sclerosis, or MS. What's its signature? What defines it?
Multiple sclerosis, MS, is indeed the most common and well-known demyelinating disorder. It's an autoimmune disease, characterized by distinct episodes of neurological symptoms that are separated in time, and those symptoms are caused by patchy lesions in the white matter of the brain and spinal cord that are separated in space. It affects about 1 in 1,000 people in Western countries and is twice as common in women as in men, typically starting in adulthood. Most individuals with MS experience a relapsing remitting course, meaning they have periods of new or worsening neurological symptoms, a relapse, followed by periods of partial or complete recovery, remission. While the frequency of these relapses might decrease over time, most patients eventually experience a steady neurological deterioration, which we believe reflects the accumulation of secondary axon damage, even if myelin is partially repaired. The underlying problem in MS is an autoimmune response, where the body's own immune system mistakenly attacks components of the myelin sheath. This is influenced by a complex interplay of both genetic and environmental factors. For example, having a first-degree relative with MS significantly increases your risk, and there's a strong association with specific variations in our immune system genes. Environmentally, there's a fascinating geographical variation, with higher prevalence further from the equator. Low vitamin D levels, which can influence immune function, are a proposed link. The immune mechanisms involve specific types of T cells, immune cells, that react against myelin antigens. These cells then release signaling molecules that activate other immune cells, like macrophages, which directly cause the demyelination. We also know that B cells, another type of immune cell, and antibodies play a role, as therapies that deplete B cells can reduce the number of active lesions. The trigger for this autoimmune attack is still unclear, though certain viral infections like Epstein-Barr virus have been proposed.
So what does this ongoing battle look like inside the brain? What do these MS lesions or plaques actually look like pathologically?
Morphologically, MS is fundamentally a disease of the white matter, the brain's wiring. When you look at an affected brain, particularly in fresh tissue, the lesions appear as firm, somewhat depressed, glassy, gray-tan patches, which are called plaques. These plaques have sharply defined borders and are best seen with special stains that highlight myelin. They vary greatly in size, from microscopic to large and confluent. Common locations include areas adjacent to the fluid-filled ventricles in the corpus callosum, the large band connecting the two brain halves, and in the optic nerves, brainstem, and spinal cord. Under the microscope, an active plaque is a microscopic battleground. You see ongoing myelin breakdown, lots of foamy macrophages engulfing myelin debris, and a significant presence of lymphocytes clustered around small blood vessels. Crucially, while myelin is largely absent in these areas, the underlying axons are relatively preserved at this active stage.
The astrocytes also undergo reactive changes. In contrast, a quiescent or inactive plaque shows that the inflammatory cells have largely disappeared. There's little to no myelin left, and the area is dominated by dense scar tissue formed by reactive astrocytes. Unfortunately, in these older plaques, many axons are also greatly diminished. We also see shadow plaques, which show less severe myelin loss, sometimes interpreted as partial remyelination, but the CNS's ability to repair myelin is limited, so most remaining axons stay unmyelinated.
That paints a vivid picture of the disease's progression locally. How do these lesions translate to symptoms for the patient? What's the clinical picture?
Because MS lesions can occur anywhere in the central nervous system, they can cause a wide range of symptoms, though certain patterns are more common. A frequent initial symptom is unilateral visual impairment, often called optic neuritis, caused by inflammation of the optic nerve. However, it's important to note that only a minority of individuals with optic neuritis will go on to develop full-blown MS script. Other common symptoms include problems related to brainstem involvement, like uncoordinated movements, involuntary eye movements, or double vision. Lesions in the spinal cord can lead to weakness or sensory problems in the limbs, spasticity, and loss of bladder control. When we examine the cerebrospinal fluid in MS, we typically see mildly elevated protein and, in about a third of cases, an increase in white blood cells. A key diagnostic finding is the presence of elevated IgG levels and specific oligoclonal bands of IgG in the CSF, which signal an active immune response within the CNS. MRI is invaluable for assessing disease progression and detecting those silent plaques. While current treatments, which are mainly immunosuppressive or immunomodulatory, can slow progression, they are not curative.
This next one, neuromyelitis optica, or NMO, sounds quite similar to MS on the surface. How do we distinguish it? What makes it different?
That's a great observation, and for a long time, NMO was considered a variant of MS script. But it's now clearly recognized as a distinct disorder with a very specific signature. NMO is characterized by synchronous or nearly synchronous bilateral optic neuritis, inflammation of both optic nerves, and spinal cord demyelination. Key distinctions from MS include a greater predominance in women, often poorer recovery from the first attack, and crucially, the presence of specific antibodies against aquaporin 4. Aquaporin 4 is a major water channel found primarily on astrocytes, and these antibodies are believed to be directly pathogenic. Pathologically, areas of demyelination in NMO show a marked loss of aquaporin 4. In the damaged white matter, you'll see necrosis, and an inflammatory infiltrate that often includes neutrophils and eosinophils, less typical in MSA. There's also deposition of immunoglobulins and complement components around blood vessels. Treatment for acute attacks involves powerful anti-inflammatory drugs or plasma exchange, while long-term treatment focuses on agents that decrease antibody levels or inhibit the complement system.
And the next two, acute disseminated encephalomyelitis, ADEM, and acute necrotizing hemorrhagic encephalomyelitis, ANHE, these sound like very acute, widespread demyelination events.
They are, and they're important to distinguish from MS Gohan. Acute disseminated encephalomyelitis, or ADEM, is a diffuse single-episode demyelinating disease that typically follows a viral infection or rarely a vaccination. Symptoms usually appear 1 to 2 weeks after the triggering event, including headache, lethargy, and sometimes coma, but without the focal neurological findings typical of MS relapses. All the brain lesions appear at the same stage, consistent with a single acute event. While the clinical course can be rapid with some mortality, most patients usually recover completely. Acute necrotizing hemorrhagic encephalomyelitis, or ANHE, also known as Weston-Hurst disease, is a more fulminant and severe form of CNS demyelination, affecting primarily young adults and children. It's almost always preceded by a recent upper respiratory infection. Histologically, it shares similarities with ADEM, but causes much more severe tissue damage. Many patients tragically die, and most survivors have significant long-term neurological deficits. These disorders are believed to be acute autoimmune reactions against myelin, often triggered by an infection, with ANHE representing a hyperacute variant.
This next condition, central pontine myelinolysis, sounds incredibly specific, targeting just one region of the brain.
It is, and it's a critical condition to understand because it's often iatrogenic, meaning caused by medical treatment. Central pontine myelinolysis, or CPM, is an acute disorder characterized by a very specific and symmetric loss of myelin in the base of the pons, a vital part of the brainstem. It most commonly develops 2 to 6 days after the rapid correction of hyponatremia, abnormally low sodium levels. Because of this, it's now often referred to as osmotic demyelination syndrome, as rapid increases in the body's osmolality appear to damage the oligodendrocytes, the myelin-producing cells, through mechanisms that are still not fully understood. A key pathological feature is the striking absence of inflammation in the lesions. And importantly, the neurons and their axons are generally well preserved, only the myelin is lost. All the lesions appear to be at the same stage, reflecting their synchronous onset. While originally described in the pons, similar lesions can occur in other brain regions, though certain areas are typically spared. Clinically, it presents as rapidly evolving quadriplegia and can be fatal or lead to severe long-term deficits, including the locked-in syndrome, where a person is conscious but completely unable to move or communicate except for eye movements. This highlights why the correction of hyponatremia must always be done slowly and carefully.
So it seems demyelinating diseases are a core challenge in neurology precisely because myelin is so fundamental for every nerve function.
Exactly. The critical role of myelin in rapid and efficient nerve conduction means that its loss, even partial, causes widespread and severe neurological deficits. These diseases fundamentally involve the breakdown of previously normal myelin, often driven by inflammatory or autoimmune processes, with secondary axon damage emerging as the disease progresses over time. Multiple sclerosis is the classic autoimmune relapsing remitting form, with the accumulation of deficits over time largely reflecting underlying axon loss. Other forms like NMO, ADEM, ANHE, and CPM, while less common, are often acute and monophasic and frequently follow infections or, in the case of CPM, severe electrolyte imbalances.
Now let's move into the really challenging area of neurodegenerative diseases. This is a huge and often heartbreaking category where neurons progressively die. What's the fundamental problem underlying so many of these conditions? It seems like a central theme.
You're right. This is a massive and incredibly important area of pathology. These disorders are all characterized by the progressive, relentless loss of specific groups of neurons, often those that share common functions, which then leads to a relatively predictable set of signs and symptoms. A fascinating and common pathological process uniting most of these seemingly disparate conditions is the accumulation of abnormal protein aggregates within or around neurons. This is why we often refer to them as proteinopathies. These protein aggregates can arise from several mechanisms: a genetic mutation that causes a protein to misfold, a disruption in the cell's normal machinery for processing or clearing proteins, or even subtle imbalances between how much protein is made and how much is cleared, perhaps due to aging, genetics, or environmental factors. Regardless of their origin, these aggregated proteins are typically resistant to the cell's normal degradation machinery and are found in abnormal locations within neurons. Current thinking is that the large, microscopically visible aggregates may not be directly toxic themselves. Instead, their formation might be a protective mechanism to sequester smaller, more toxic forms of the proteins, called oligomers. However, if too much of a protein gets shunted into these aggregates, the protein can't perform its normal function, which also contributes to cell injury. And here's where it gets truly remarkable. Emerging evidence suggests that these protein aggregates can actually behave like prions, meaning they can spread from one cell to another, inducing further protein misfolding and aggregation as they go.
That spreading idea of misfolded proteins sounds like a really unique and, frankly, terrifying concept. Almost infectious in a way, but from within.
It truly is revolutionary in our understanding of neurodegeneration. Prion diseases are the prime example of this spreading phenomenon, where a pathogenic protein acquires characteristics that make it behave almost like an infectious agent. These are rapidly progressive neurodegenerative disorders caused by the aggregation and intercellular spread of a misfolded version of the normal prion protein, or PRP. These diseases can arise spontaneously, be inherited, or chillingly be transmitted. Examples in humans include Creutzfeldt-Jakob disease, Gerstmann-Straussler-Scheinker syndrome, fatal familial insomnia, and Kuru. In animals, we see scrapie in sheep and mad cow disease, or bovine spongiform encephalopathy. All of them share the hallmark of a peculiar spongiform change in the brain, where brain tissue develops tiny sponge-like holes, and clinically they all cause rapidly progressive dementia. The pathogenesis is conceptually groundbreaking. The normal PRP protein, found in all our cells, undergoes a conformational change from its normal shape to an abnormal misfolded and highly stable form called PRPSC. This misfolded PRPSC is resistant to breakdown by proteases, and its accumulation causes the pathological changes. Once generated, PRPSC acts like a template, promoting the conversion of other normal PRP molecules into the misfolded PRPSC form, leading to a chain reaction. This explains the transmissible forms, like iatrogenic CJD, variant CJD, and Kuru.
The idea of the cell-to-cell spread of misfolded protein aggregates within an individual is now a central hypothesis connecting prion diseases to other major neurodegenerative disorders like Alzheimer's and Parkinson's.
Let's talk about Creutzfeldt-Jakob disease, or CJD specifically. What's the core problem there, and how does it typically manifest?
Creutzfeldt-Jakob disease, or CJD, is the most common of the prion diseases, though it's still extremely rare, with about 1 case per million people per year for the sporadic form, which accounts for 90% of cases. Familial forms are caused by specific gene mutations. It typically affects people in their 60s and 70s. Tragically, there are well-documented cases of iatrogenic transmission, meaning it was accidentally transmitted through contaminated corneal or dural transplants or contaminated human growth hormone from cadavers. Clinically, it often starts with subtle memory problems and behavioral changes, followed by a very rapid decline into severe dementia, often accompanied by involuntary jerking movements called myoclonus. The disease is almost uniformly fatal, with an average survival of only about 7 months from symptom onset. Morphologically, because of its rapid progression, there's usually little to no visible brain shrinkage. The pathognomonic, or diagnostically unique finding, is spongiform transformation of the cerebral cortex and deep gray matter structures, where the brain tissue appears like a sponge, filled with many small, empty vacuoles. In advanced cases, there's severe neuronal loss and scar tissue formation, and these vacuolated areas can expand into larger cyst-like spaces. Crucially, there's no inflammation. Extracellular aggregates of the abnormal PRP, called Kuru plaques, can also be found. All forms of prion disease can be diagnosed by immunohistochemical staining for the abnormal protease-resistant PRP-SC. A distinct form, variant Creutzfeldt-Jakob disease, or VCJD, emerged in the UK in the mid-1990s. It differs from classical CJD in important ways. It affects younger adults, behavioral disorders are often prominent early, and the neurological decline is slower. This form was tragically linked to exposure to bovine spongiform encephalopathy, or mad cow disease, likely through contaminated food or blood transfusions. Public health measures have been effective in limiting its spread.
Okay, now let's turn to the most common cause of dementia, Alzheimer's disease. What's its fundamental problem? What defines it at its core?
Alzheimer's disease, AD, is indeed the most common cause of dementia in older adults, with its incidence dramatically increasing with age. It usually begins as an insidious, gradual impairment of higher cognitive functions. Over 5–10 years, it relentlessly progresses, leading to profound deficits in memory, spatial orientation, judgment, personality, and language, eventually leaving individuals profoundly disabled, mute, and immobile. While definitive diagnosis requires post-mortem brain examination, clinical and radiological methods are now highly accurate in life. The fundamental abnormality in Alzheimer's is the accumulation of 2 key proteins, amyloid beta, AA, and tau. These proteins build up in specific regions of the brain, likely due to a combination of excessive production and, more importantly, defective clearance. The 2 defining pathological hallmarks are amyloid plaques deposits of aggregated peptides in the brain tissue, and neurofibrillary tangles aggregates of a hyperphosphorylated tau protein, initially forming inside neurons and then persisting even after the neuron dies. Both contribute significantly to neural dysfunction, and their complex interplay is a critical, though still not fully understood, aspect of the disease. Evidence strongly suggests that the generation of amyloid beta is the critical initiating event for Alzheimer's. While tau deposits are seen in other dementias, they don't lead to full-blown Alzheimer's without AP. Genetic evidence also points to AP mutations in the APP gene, which makes the precursor protein for AP, and in genes that control how AP is cut and processed, like prosenolins, all lead to increased AP production, particularly the highly aggregation-prone AP42 form. This AP42 first forms small, toxic oligomers which are believed to cause the neuronal dysfunction, and then larger aggregates and fibrils that form the visible plaques. The role of tau is also absolutely critical. Neurofibrillary tangles are composed of tau protein, which normally stabilizes microtubules, the internal skeletons of axons. In Alzheimer's, tau shifts location, becomes abnormally hyperphosphorylated, and loses its ability to bind microtubules. Tangle formation is a central feature, and the increasing number of tangles actually correlates better with the degree of dementia than the plaques do. How tangles injure neurons is still unclear, but it may involve a stress response or disruption of the neuron's internal transport system. Other genetic factors also influence risk. The ApoE gene, particularly the A4 allele, significantly increases AD risk and lowers the age of onset. It seems to promote APOR deposition and also exacerbates tau-mediated neurodegeneration. We're also learning about the role of inflammation. AP deposits can trigger an inflammatory response from microglia and astrocytes. While this might initially help clear the peptide, it can also lead to the release of damaging mediators, contributing to altered tau, oxidative stress, and even aberrant synaptic pruning. Morphologically, the brain in Alzheimer's shows variable cortical atrophy, shrinkage of the brain's outer layers, with narrowed folds and widened grooves, most pronounced in the frontal, temporal, and parietal lobes. As the brain shrinks, the fluid-filled ventricles inside expand, a phenomenon called hydrocephalus ex vacuo. The medial temporal lobe structures, including the hippocampus, are involved early and show severe atrophy in later stages. Under the microscope, the major abnormalities are neuritic, senile plaques, and neurofibrillary tangles. There's also progressive severe neuronal loss and reactive scarring in the affected regions. Neuritic plaques are focal, spherical collections of abnormal dilated nerve processes, often surrounding a central core of amyloid protein. These dystrophic nerve processes contain tau aggregates, and the plaques are surrounded by microglia and reactive astrocytes. They are abundant in the hippocampus, amygdala, and outer cortex. We also see diffuse plaques, which are IRO deposits without the surrounding nerve process abnormalities, thought to be an earlier stage of plaque development. Neurofibrillary tangles are distinct bundles of tau-containing filaments found within the cytoplasm of neurons. They often have an elongated flame shape. They're clearly visible with special stains like silver or tau immunohistochemistry. These tangles are common in cortical neurons, especially in the entorhinal cortex and hippocampus. Because they are insoluble, they persist even after the neuron dies, remaining as ghost or tombstone tangles. While characteristic of AD, tangles are also found in other neurodegenerative diseases. Other common findings in AD include cerebral amyloid angiopathy, CAA, where amyloid deposits in blood vessel walls. Clinically, AD shows a slow, relentless progression, often over 10 years. It begins with forgetfulness, progressing to language deficits, loss of math skills, and loss of learned motor skills. In the final stages, individuals become incontinent, mute, and unable to walk, often dying from secondary complications like pneumonia. Recent advances in biomarkers like imaging 8A deposition or measuring proteins in CSF now allow us to identify preclinical stages of AD, shifting the focus of drug trials to early intervention, hoping to slow or prevent disease progression.
So it sounds like there are other forms of dementia that primarily affect the front and sides of the brain, which are distinct from Alzheimer's in terms of symptoms and maybe even underlying proteins.
Yes, absolutely. These are the frontotemporal lobar degenerations, or FTLDs, a diverse group of disorders characterized by focal degeneration of the frontal and/or temporal lobes. Clinically, they are typically distinguished from Alzheimer's by the prominence of personality, behavioral, and language changes that often precede significant memory loss. While global dementia does occur as disease progresses, these are common causes of early-onset dementia, affecting individuals under 65 at a similar frequency to Alzheimer's. Definitive diagnosis still requires postmortem brain examination. Like most neurodegenerative diseases, FTLDs are associated with specific protein inclusions within cells. The two most common patterns involve either tau protein inclusions, called FTLD tau, or TDP43 protein inclusions, known as FTLD-TDP. Both have inherited and sporadic forms, and interestingly, there isn't a fixed relationship between the clinical presentation and the specific type of protein inclusion. In FTLD tau, affected brain regions show progressive neuronal loss and scarring, along with cytoplasmic inclusions of tau protein in neurons.
Unlike Alzheimer's, which has both A and tau, FTLD tau exclusively features tau aggregation. The inclusions can look like Alzheimer's tangles or appear as smooth, rounded big bodies. The pathogenesis is linked to mutations in the MAPT gene, which encodes tau, or can be sporadic. Tau's normal role involves microtubules. When tau becomes abnormally hyperphosphorylated or its isoforms are imbalanced, it aggregates. How abnormal tau damages neurons is still debated, likely involving both loss of normal function and toxic gain of function. Morphologically, there is shrinkage of frontal temporal lobes, neuronal loss, scarring, and tau tangles. A classic subtype, PIC disease, shows pronounced, often asymmetrical atrophy with characteristic balloon neurons in distinct cytoplasmic PIC bodies. FTLD-TDP is diagnosed when patients have clinical frontotemporal dementia and brain atrophy, but their cellular inclusions contain TDP43, an RNA binding protein, instead of tau. Clinically, presentation involves behavioral problems or language deficits, similar to FTLD tau. Inherited forms are caused by mutations in 3 different genes. The most common is a repeat expansion in the C9orf72 gene, which also causes ALS.
Mutations in TAR-DBP encoding TDP43 and GRN encoding progranulin are also causes. The exact mechanisms linking these mutations to TDP43 aggregation are complex, often involving problems with RNA processing or stress response. Morphologically, you see variable atrophy, neuronal loss, and scarring. TDP-43, normally in the nucleus, is found in various cytoplasmic or nuclear inclusions.
Okay, now let's talk about Parkinson's disease. This is famously known as a disorder of movement and deeply associated with the neurotransmitter dopamine. What's its core problem?
Parkinson's disease, PD, is a neurodegenerative disorder primarily characterized by a hypokinetic movement disorder, meaning movements are reduced and slowed. This stems from the progressive loss of specific dopaminergic neurons in a part of the brain called the substantia nigra. The classic clinical syndrome, Parkinsonism, involves a diminished facial expression, stooped posture, slowed voluntary movements, a shuffling gait, muscle rigidity, and the pill-rolling tremor. While PD is the most common cause, similar symptoms can be induced by medications or toxins. The clinical diagnosis of PD is based on this set of symptoms without known etiology, often confirmed by response to L-CADOPA, which replenishes dopamine. What's fascinating is that the disease isn't just restricted to those dopamine neurons. While substantia nigra degeneration causes the motor symptoms, it represents a mid-stage of a progressive disease that starts lower in the brainstem and eventually spreads to the cortex, leading to cognitive impairment later on. The dopaminergic neurons project to the striatum. Degeneration reduces striatal dopamine. Motor symptom severity relates to this deficiency and is partly corrected by L-CADOPA.
However, L-dopa doesn't reverse structural changes or stop progression, and its effectiveness diminishes. Deep brain stimulation is used for motor symptoms. Toxins like MPTP mimic the disease, and pesticide exposure is a risk factor, while caffeine and nicotine seem protective. The pathogenesis of PD involves protein accumulation, mitochondrial abnormalities, and neuronal loss. Most cases are sporadic, but genetic forms offer insights. A key player is alpha-synuclein. Mutations in its gene were first identified in dominant PD. Isonuclein is the major component of the Lewy body, the diagnostic hallmark. Like as in AD, isonuclein forms toxic oligomers and appears to spread neuron to neuron, prion-like. The gut-brain hypothesis suggests it might start in the gut and spread via the vagus nerve. Mitochondrial dysfunction is also implicated, especially in recessive PD linked to DJ1, BNK1, and Parkin mutations, involved in oxidative stress protection and clearing damaged mitochondria. Heterozygous mutations in glucocerebrosidase, GBA, are the most important genetic risk factor for sporadic PD, suggesting lysosome autophagy pathway dysfunction contributes. Mutations in LRRK2 are the most common cause of dominant PD. Morphologically, a characteristic finding is pallor of the substantia nigra and locus ceruleus due to pigmented neuron loss. Under the microscope, the diagnostic feature is the Lewy body, cytoplasmic eosinophilic inclusion with a dense core and pale halo, composed mainly of isonuclein filaments. They're found in the substantia nigra and other brainstem nuclei. Areas of neuronal loss show reactive scarring. Abnormal Lewy neurites are also seen.
What's the relationship between Parkinson's and dementia with Lewy bodies? They sound very closely related.
They're very much interconnected, forming a spectrum. About 10% to 15% of PD patients eventually develop dementia. Dementia with Lewy bodies, DLB, is a distinct clinical entity characterized by fluctuating cognitive abilities, vivid visual hallucinations, and prominent frontal lobe symptoms, often with motor symptoms appearing later. In some cases, DLB is essentially advanced PD, where isonuclein aggregates have spread to cortical neurons. In others, dementia is the first symptom, suggesting a different spread pattern. Morphologically, cortical Lewy bodies in DLB are less distinct than brainstem ones, but are also primarily isonuclein. Immunostaining reveals Lewy neurites. Grossly, there's depigmentation of the substantia nigra, but relative preservation of the cortex. The cortical Lewy body burden can be low. The mechanism of cognitive havoc is unclear. Some evidence suggests the burden of smaller, toxic isonuclein oligomers may be more critical than the visible Lewy bodies.
So it sounds like not all Parkinsonism, that collection of motor symptoms, is actually Parkinson's disease. There are other related conditions.
You're absolutely correct. The clinical syndrome of Parkinsonism reflects dysfunction in the brain's dopamine pathways. However, there are other neurodegenerative disorders that also include Parkinsonism. These are often minimally responsive to LDOPA and are distinguished by additional unique signs. We call these atypical Parkinsonian syndromes, or Parkinson plus syndromes. They include progressive supranuclear palsy, PSP, and cortical basal degeneration, CUD, both tauopathies, and multiple system atrophy, MSA, and isonucleinopathy. Progressive supranuclear palsy, PSP, is a tauopathy characterized by progressive truncal rigidity, balance problems, frequent falls, and difficulty with voluntary eye movements. Other common symptoms: neck dystonia, speak-swallowing issues, mild dementia, onset 5th, 7th decades, fatal in 5 to 7 years. Pathologic hallmark, tau-containing inclusions in neurons glia in specific deep brain regions. Cortical-basal degeneration, CBD, is another progressive tauopathy. Features include extrapyramidal rigidity,
asymmetric motor disturbances, jerky limbs, and impaired higher cortical function apraxia. Cognitive decline typically later. Shares many features with PSP, but tau lesions are more shifted towards cerebral cortex involvement. Morphologically, cortical atrophy, severe neuronal loss, gliosis balloon neurons, various tau-positive inclusions in astrocytes and neurons. Multiple system atrophy, MSA, is a sporadic disorder affecting several functional systems. Its unique characteristic is isonuclein inclusion, specifically in oligodendrocyte cytoplasm. Primary changes are in glial cells, associated with white matter tract degeneration. Multiple refers to three common circuits: striatonegral, Parkinsonism, olivopontocerebellar, ataxia, and autonomic nervous system, autonomic dysfunction. One may dominate initially, but others usually become affected. Pathogenesis involves isonuclein, but origin in oligodendrocytes is perplexing. They might acquire aggregates from injured neurons. Morphologically, atrophy matches clinical presentation, cerebellum pons versus substantia nigra striatum. Diagnostic glial cytoplasmic inclusions contain isonuclein.
Okay, let's talk about Huntington disease. This is a famous genetic disorder that causes those uncontrollable jerky movements. What's happening there?
That's Huntington disease, H-type, a truly devastating autosomal dominant disease. It's caused by the degeneration of specific neurons in the striatum, leading to a progressive movement disorder, jerky, hyperkinetic movements called chorea, and dementia. Later, bradykinesia, rigidity, relentlessly progressive, fatal, average course 15 years. The pathogenesis is a classic example of a polyglutamine trinucleotide repeat expansion disease, caused by an abnormal expansion of a CAG repeat in the HTT gene. Normal, 635 repeats. Disease, 35 repeats. Longer repeats mean earlier onset. Repeat expansion during spermatogenesis leads to earlier onset in the next generation. Anticipation. There is no sporadic form. Expanded polyglutamine causes toxic gain of function. Huntington is expressed everywhere, but effects are selective to CNS. Intranuclear inclusions are a hallmark but may be neuroprotective. Transcriptional dysregulation and disrupted protein degradation are implicated. Aggregated Huntington might transfer between cells, prion-like. Clinically, loss of striatal neurons, which dampen motor activity, leads to increased motor output. Choreothetosis. Cognitive changes relate to cortical neuronal loss. Onset. 4th, 5th decades, related to repeat length. Motor symptoms often precede cognitive ones. Movement disorders is choreiform. Early cognitive issues progress to severe dementia. Death often from pneumonia. Suicide rate elevated. Genetic screening raises ethical issues. Morphologically, the brain is small, with striking atrophy of the caudate nucleus and putamen. Dorsal striatum. Ventricles dilate. Frontal lobe atrophy common, microscopically. Profound striatal neuronal loss, especially medium-sized spiny gadiarchic neurons. Extensive gliosis. Severity correlates with symptoms. Protein aggregates with Huntington found in striatal cortical neurons.
So, are there degenerative diseases that specifically target the cerebellum, affecting coordination and the spinal cord pathways?
Yes, these are the spinocerebellar degenerations, a broad group sharing neuronal loss dysfunction in cerebellum, spinal cord, peripheral nerves. Very heterogeneous genetically, age of onset, symptoms. Genetic analysis improved classification, but not much insight into pathogenesis treatment yet. Spinocerebellar ataxia, SEA, refers to autosomal dominant forms. Over 35 subtypes, 3 main mutation types: polyglutamine diseases, CAG repeat expansion like HD, 7 SCA types, mutated protein accumulates in neurons, non-coding repeats, expansion like myotonic dystrophy, 5 SCA forms, pathogenic link obscure, other mutations, deletions, insertions, point mutations in signaling proteins. Friedreich ataxia is autosomal recessive, PAM clumsiness dysarthria, absent deep tendon and reflexes, impaired joint vibration sets. Pescavus kyphoscoliosis common, wheelchair-bound 5 years, life expectancy 40-50 years. Cardiomyopathy, major cause of death. Diabetes common, pathogenesis. GAA trinucleotide repeat expansion and frataxin gene intron. Frataxin is mitochondrial protein for iron-sulfur cluster enzyme assembly. Low frataxcopic decreased mitochondrial energy production, increased free iron oxidative stress. Disease from loss of frataxin function. Ataxia telangiectasia is another autosomal recessive disorder. Early childhood ataxia telangiectasia, dilated vessels, immunodeficiency, caused by mutations in ATM gene, critical for DNA double-strand break repair. Leads to progressive neurodegeneration, high risk of lymphoid cancers, death usually in second decade.
Now, let's talk about amyotrophic lateral sclerosis, often called Lou Gehrig's disease, which famously impacts motor neurons. What defines this condition?
Yes, amyotrophic lateral sclerosis, or ALS, is a progressive disorder defined by the relentless loss of both upper motor neurons in the cerebral cortex and lower motor neurons in the spinal cord and brainstem. This leads to muscle denervation and profound weakness, incidence 2 per 100,000. Men slightly more than women, commonly 5th decade or later. Mostly sporadic, 80%, but up to 20% familial. Pathogenesis. Both sporadic and familial ALS involve motor neuron degeneration, often with toxic protein accumulation. Nearly 24 genes identified for familial ALS, mostly dominant. SOD1 mutations, 20% familial cases, cause adverse gain of function. Mutant SOD1 misfolds, forms aggregates, disrupts protein breakdown, axonal transport, mitochondrial function. C9orf72 repeat expansion is most common mutation for ALS and FTLD. Accounts for up to 40% familial ALS, some sporadic. Leads to toxic peptide deposits. PDP43 and FUS mutations also cause ALS, FTLD. These encode RNA-binding proteins involved in stress granules. Link unclear, may involve altered RNA processing or protein aggregation stress. Morphologically, you see thin anterior spinal cord roots, lower motor neuron loss. Precentral gyrus atrophy in severe cases.
Microscopically, reduced anterior horn neurons, reactive gliosis, similar changes in cranial nerve nuclei. Remaining neurons show Bunini bodies, PDP43 inclusions, except in SOD1 FUS cases. Skeletal muscles show neurogenic atrophy. Upper motor neuron loss, the corticospinal tract degeneration. Clinically, early symptoms often asymmetric hand weakness, cramping, spasticity. Progression, muscle bulk diminishes, fasciculations, twitches, eventually. Respiratory muscle involvement, more pneumonia. Most have upper-lower motor neuron signs, but other patterns exist. Progressive muscular atrophy, primary lateral sclerosis, bulbar ALS. Prognosis poor, most life 2 years after diagnosis. Extraocular muscle spared till late, often associated with FTLD, TDP43 pathology. Other motor neuron diseases include spinal and bulbar muscular atrophy, Kennedy disease, X-linked polyglutamine repeat disease, distal limb bulbar weakness, degeneration of lower motor neurons, also androgen sensitivity, slow progression, normal lifespan, spinal muscular atrophy, SMA, childhood disorders, marked lower motor neuron loss, half-these weakness, severity varies, type I fatal early, type 3 milder. Caused by loss of SMN protein, involved in spliceosome assembly, due to SMN1 gene mutations. Severity depends on SMN2 copy number. Novel gene therapy is now available.
It's truly striking how many of these diverse diseases, from Alzheimer's to Parkinson's to ALS, all seem to involve this common theme of misfolded proteins accumulating, even if the clinical presentation is wildly different.
Indeed, that's one of the most profound unifying concepts emerging. Neurodegenerative diseases are fundamentally defined by progressive neuronal loss in specific circuits, almost universally accompanied by abnormal protein aggregates. The specific phenotype reflects which brain regions are affected, not just the inclusion type. They can be grouped by presentation: dementias, movement disorders, ataxias, motor neuron diseases. Prion diseases are unique for their transmissible misfolded protein. AD, FTLD, DLB are major dementias with distinct proteins. PD and atypical Parkinsonian syndromes involve other proteinopathies. ALS is the most common motor neuron disease, with diverse genetic causes often linked to protein issues.
Okay, moving beyond genetics and degeneration, what about conditions that stem from faulty metabolism that isn't necessarily inherited or from exposure to toxins? How do these acquired issues affect the CNS?
Right. These genetic metabolic diseases and acquired toxic and metabolic disorders cover a wide range, and they often present with distinct neurological patterns. The brain's incredibly high metabolic demand makes it particularly vulnerable. Genetic metabolic diseases disrupt essential processes in neurons or glia. They typically have an early onset and are relentlessly progressive. The earlier they start, generally the more aggressive they are. We can organize them based on the affected cell type or location. Neuronal storage diseases are mostly autosomal recessive. They result from deficiencies in enzymes needed to break down certain complex molecules like sphingolipids or mucopolysaccharides. This leads to the accumulation of storage material within neurons, causing cell death. Neurologic symptoms often include seizures and a generalized loss of function. Examples include Tay-Sachs and Niemann-Pick diseases. Leukodystrophies are another group, mostly autosomal recessive, caused by mutations in genes critical for myelin synthesis or breakdown. This leads to progressive damage to myelinated axons, with devastating consequences, especially in children. They differ from demyelinating diseases like MS because they represent an inability to form or maintain myelin properly from the start, often presenting earlier with diffuse symmetric changes on imaging. Crab disease results from the deficiency in an enzyme needed to break down galactosarucoside. This leads to the accumulation of a toxic byproduct, galactosylsphingosine, which damages oligodendrocytes. It's rapidly progressive, starting in infancy, with survival rarely beyond 2 years. Morphologically, you see myelin loss in aggregates of engorged macrophages called globoid cells. Metachromatic leukodystrophy involves a deficiency in aryl sulfatase A, leading to the accumulation of sulfatides, which are toxic to white matter. Histologically, you see demyelination in macrophages filled with sulfatide material that stains distinctively, metachromasia. Adrenal leukodystrophy is X-linked, caused by mutations affecting the transport of very long-chain fatty acids into peroxisomes for breakdown. This leads to their accumulation, causing aggressive CNS, peripheral nerve, and adrenal gland disease. Boys typically present with behavioral changes and adrenal insufficiency. White matter shows myelin loss, inflammation, and scarring. There are many other rare leukodystrophies with various genetic causes. Mitochondrial encephalopathies result from disorders of oxidative phosphorylation, the process mitochondria use to generate energy, ATP. Since neurons critically depend on this process, these disorders often severely affect the CNS, as well as other high-energy tissues like skeletal muscle. Mitochondria have their own small genome, inherited maternally, but most mitochondrial proteins are encoded by nuclear genes. This leads to complex inheritance patterns. A key feature is heteroplasmy, where cells contain a mix of normal and mutated mitochondrial DNA, leading to variable disease expression. CNS involvement selectively targets neurons. Disrupted energy generation leads to elevated lactate levels. Examples include MELAS, characterized by stroke-like episodes and lactic acidosis, MERF, with myoclonic epilepsy and characteristic ragged red fibers in muscle biopsies, and Lee syndrome, a severe infancy disease with widespread brain tissue destruction.
So metabolic disorders, especially genetic ones, can have devastating effects, particularly if they show up early in life.
Yes, mutations disrupting these fundamental pathways are often severe and progressive. The key is that diseases with earlier onset tend to be more severe. Neuronal storage diseases show material accumulation, leukodystrophies involve myelin problems, and mitochondrial encephalomyopathies affect energy generation, often in multiple tissues.
Moving on from genetic predispositions, how do external factors like toxins or dietary deficiencies affect the CNS? These acquired issues seem quite common.
Absolutely. Acquired metabolic and toxic diseases are common causes of neurologic illness. Again, the brain's high metabolic demand makes it particularly vulnerable. Vitamin deficiencies, especially B vitamins, are critical. Two distinct syndromes stand out. Thiamine, vitamin B1, deficiency causes Wernicke-Korsakoff syndrome. Wernicke encephalopathy is the acute phase, psychosis, eye movement issues, reversible with thiamine. Untreated, it leads to irreversible Korsakoff syndrome, severe short-term memory loss, confabulation. Common in chronic alcoholism, but also other gastric disorders. Morphologically, hemorrhage and necrosis in mammillary bodies and around ventricles. Memory issues linked to thalamic damage. Vitamin B12 deficiency causes subacute combined degeneration spinal cord. It's a defect in myelin formation affecting descending tracts. Symptoms develop over weeks. Numbness, tingling, ataxia in legs, progressing to spastic weakness, potentially paraplegia. Prompt B12 replacement helps, but recovery poor, paralysis complete. Morphology, myelin swelling the ejaculals, later axon degeneration, often starting mid-thoracic cord. Neurologic consequences also rise from systemic metabolic disturbances.
Hypoglycemia, low blood sugar effects resemble oxygen deprivation. Large cortical pyramidal neurons, hippocampus, CA1 summer sector, and Purkinje cells are vulnerable. Severe prolonged hypoglycemia causes widespread injury. Hyperglycemia, high blood sugar, common in uncontrolled diabetes, usually doesn't cause major brain structural changes. Patients are dehydrated, confused, stuporous. Fluid correction must be gradual to avoid cerebral edema. Hepatic encephalopathy, impaired liver function, causes glial changes. Elevated ammonia and inflammation lead to Alzheimer type 2 astrocytes and gray matter. And then there are toxic disorders. Carbon monoxide, CO, impairs oxygen transport and blocks mitochondrial oxygen use. Causes selective injury to cortical layers, E5E, hippocampus, Purkinje cells. Unique pattern. Bilateral globus pallidus necrosis. Later demyelination possible. Ethanol, chronic abuse, causes Wernicke-Korsakoff and direct toxic effects. Cerebellar dysfunction, 1% chronic alcoholics, leads to ataxia, unsteady gait. Morphology, atrophy loss of granule cells, especially superior anterior vermis, later Purkinje cell loss. Radiation exposure, accidental or therapeutic, can cause acute symptoms, nausea, confusion, coma. Delayed effects, headaches, nausea, papilledema. Pathology, large areas of coagulative necrosis, mainly white matter. Edema, vascular damage. Radiation plus methotrexate can be worse, can induce secondary tumors years later.
It's a really sobering reminder that our diet, our environment, the substances we're exposed to can profoundly impact brain health, sometimes in very specific ways.
Indeed. Vitamin deficiencies, especially B vitamins, notably affect the nervous system. The CNS's high metabolic demand makes it highly susceptible to hypoglycemia and carbon monoxide. Chronic alcohol exposure can cause distinct brain injuries, like cerebellar atrophy. And even subtle metabolic disturbances can disrupt brain function without immediately visible structural changes. It underscores the brain's sensitivity.
Finally, let's turn to tumors, a very significant and complex category of CNS pathology.
CNS tumors, both primary originating in CNS and metastatic, spreading from elsewhere, are a major challenge. They account for nearly 20% of childhood cancers, mostly posterior fossa, and similar numbers in adults, cerebral hemispheres. Some general principles are key. Pathologists classify tumors histologically, benign versus malignant, but clinical course depends heavily on growth pattern and location. Even benign tumors can be fatal if in critical areas, meaning compressing brainstem. Diffuse gliomas infiltrate widely, making complete surgical resection often impossible without major deficits. Highly malignant gliomas rarely metastasize outside CNS, but some pediatric tumors spread through CSF, drop metastases. WHO grades tumors IAV based on behavior. Malignant ones often progress to higher grades.
Let's start with gliomas, which you mentioned are the most common primary brain tumors. What are the main types?
Yes, gliomas include astrocytomas, oligodendrogliomas, and ependymomas. They likely arise from progenitor cells differentiating along glial lineages, often showing predilections for specific sites and ages. Astrocytoma. Two major categories: diffusely infiltrating, WHO grade 234, and more localized, like polycytic astrocytoma, WHO grade 1, can occur anywhere along neuroaxis. Infiltrating astrocytomas, WHO grades 230-30, 80% of adult primary brain tumors, usually cerebral hemispheres, 4th, 6th decades, present with seizures, headaches, focal deficits. Histologic grade correlates with outcome. Diffuse astrocytoma, 2. Endoplastic astrocytoma, 3. Glioblastoma, 4. Stratified by IDH1 and IDH2 mutations, IDH mutant has better prognosis. Infiltrating astrocytomas are inherently malignant, no grade 1. Pathogenesis. Glioblastoma can be primary older patients, IDH wild type, often EGF part alterations, or secondary, younger. Progression from lower grade, usually IDH mutant. Genetic changes drive cancer hallmarks, evading senescence, growth control, apoptosis resistant. Morphology. Diffuse astrocytomas are poorly defined, gray, infiltrative, expand, distort brain. Microscopically hypercellular, irregular nuclei, fibrillar background, IDH1, R132H stain, often positive. Anaplastic show more mitosis. Glioblastomas are varied, necrosis, hemorrhage, show necrosis, often with palisading cells, and/or microvascular proliferation. Small biopsies can undergrade. Clinical features depend on location rate. Grade 2 survival, 5 years, often progress. High grade enhance on MRI, leaky vessels. IDH wild-type glioblastoma prognosis very poor, median survival 15 months with treatment. IDH mutant glioblastoma better 2 to 3 years. MGMT silencing predicts chemo response. Polycytic astrocytoma, WHO grade 1, distinct, relatively benign, children, young adults, usually cerebellum. Unique histology genetics, MAP kinase pathway, for example, BRAF fusions. Grow slowly, often cured by resection. Morphologically well demarcated, often cystic with mural nodule. Biphasic histology, Rosenthal fibers, eosinophilic granular bodies characteristic. Necrosis vascular proliferation, not poor prognostic signs here.
Okay, besides astrocytomas, what about oligodendrogliomas? These resemble the myelin-producing cells. What's special about them?
Oligodendrogliomas are the other major infiltrating glioma subtype. Best prognosis among gliomas, grade corrected, defined by morphology and genetics. 5–15% of gliomas, 4th, 5th decades, often present with seizures after years, mostly cerebral hemispheres, white matter. Pathogenesis, molecularly defined by IDH mutation plus whole arm codeletion of 1p and 19q. Progression involves more changes, for example, CDKN2A deletion. Most have TERT promoter mutations. Morphology, gelatinous, gray, often cysts. Hemorrhage, calcification. Sheets of regular cells with spherical nuclei. Clear fried egg, cytoplasm halo. Delicate chicken wire capillaries, calcification up to 90%. Higher cell density, nuclear tibia mitosis, sometimes necrosis. Can arise de novo or progress, clinical features. Better prognosis than astrocytomas. Surgery, chemo, radiation. Survival's 15–20 years, grade 2. 10–15 years, grade 3. Progression takes years.
And ependymomas. These are distinctively linked to the ventricular system lining.
That's right. Ependymomas usually arise near the ependymal-lined ventricular system or spinal cord central canal. Children, typically near 4th ventricle, 5–10% pediatric brain tumors, adult site. Most common is spinal cord, often NF2 associated. Pathogenesis. Spinal ones often have NF2 mutations. Different sites, supratentorial, posterior fossa, spinal, have distinct driver mutations, not shared with infiltrating gliomas. Morphology. Solid, non-infiltrative masses. 4th ventricle ones can extend down spinal canal, moderately demarcated, but location makes removal hard. Spinal ones more resectable. Composed of fibrillary cells, regular nuclei.
Characteristic rosette canals, gland-like or perivascular pseudorosettes, cells radiating from vessel. Most are WHO grade 2. Anaplastic, grade 3, show more aggression. Grade less predictive than resection extent or molecular subtype. Variants, myxopapillary ependymomas, WHO grade 1, distinct in phylum Terminale. Subependymomas, WHO grade 1. Solid nodules and ventricles, often incidental clinical features. Posterior fossa often cause hydrocephalus. CSF spread uncommon. Complete resection key for outcome.
What about tumors that actually originate where cerebrospinal fluid is produced in the choroid plexus?
Both benign and malignant choroid plexus tumors exist, but all are quite rare. Choroid plexus papillomas, intraventricular tumors, children, lateral ventricle, adults, fourth ventricle, papillary growths mimicking normal choroid plexus, cause hydrocephalus, obstruction or CSF overproduction. Choroid plexus carcinomas, far rarer, resemble adenocarcinoma, almost always young children.
Are there tumors that show neuronal differentiation, not just glial types?
Yes, these neuronal and glioneuronal tumors are less common than glial ones, more often in children and young adults presenting with epilepsy. Gangliogliomas, WHO grade 1. Mixture of mature neuronal and glial cells, typically superficial, present with seizures. Most common neuronal tumor. Slow growing, surgery often helps epilepsy. 20–50% have activating BRAF V600E mutation, potential therapy target. Temporal lobe common, often cystic. Neoplastic ganglion cells are regularly clustered. Glial part resembles palicytic astrocytoma. Dysembryoplastic neuroepithelial tumor, DNN. Rare, benign, WHO grade 1, associated with epilepsy. Good prognosis after resection. Typically superficial temporal lobe. Multiple discrete mucin-rich nodules with oligodendrocyte-like cells and floating neurons.
And what about the primitive tumors, the embryonal neoplasms, mostly seen in children?
Yes, that's a large category, mostly pediatric. Appear primitive, undifferentiated, though limited neuronucleal differentiation often seen. Medulloblastoma, most common embryonal neoplasm, 20% pediatric brain tumors. Malignant, exclusively cerebellum by definition. Histologically, molecularly distinct subtypes, all grade 4. Rapid growth often hydrocephalus. Pathogenesis, molecular subtypes defined by alterations in cerebellar development pathways, sonic hedgehog, WNT-catenin. Different pathways associated with different locations prognosis, WNT better. 4 or 5 molecular groups identified. Morphology, often well circumscribed, gray, friable, can involve leptomeninges, microscopically. Very dense, small, primitive cells, scant cytoplasm, hyperchromatic nuclei, abundant mitosis. Homer-right rosettes common, classic subtype. Desmoplastic nodular variant, often SAH activated, has stromal response, pale islands. Large cell anaplastic variant, more aggressive. Propensity to spread via CSF, drop metastases. Critical features, highly malignant untreated, exquisitely radiosensitive. Subtype dramatically influences prognosis. WNT nearly 100%, 5-year survival, aggressive 20–30%. Trials exploring tailored therapy based on subtype targeted therapies. Other rare embryonal neoplasms exist. Classification evolving.
What about lymphomas that actually start in the brain rather than spreading there?
Yes, primary CNS lymphoma accounts for 2% extranodal lymphomas, 1% intracranial tumors. Most common CNS neoplasm in immunosuppressed. AIDS, transplant. Frequency increases after 60 in non-immunosuppressed. Primary distinguishes from secondary CNS involvement, usually meningeal. Often multifocal, can involve eye. Rarely spreads outside CNS. Majority are diffuse large B-cell lymphomas. Aggressive, worse outcomes than non-CNS equivalents. Immunosuppressed, usually EBV positive. Non-immunosuppressed, often PD-L1 amplification. Immune checkpoint target. Morphology, frequently multiple deep gray-white masses, often periventricular. Malignant cells infiltrate parenchyma, cluster around vessels, express B-cell markers. Immunosuppressed show more necrosis. EDD.
And finally, meningiomas. These are typically benign tumors that arise from the meninges, the membranes around the brain.
Yes, meningiomas are predominantly benign tumors in adults. Arise from arachnoid meningothelial cells, usually attached to dura, found on any external surface or within ventricles. Prior radiation risk factor. Other tumors can mimic dura-based masses. Pathogenesis. Most common genetic change. Chromosome 22 loss, includes NF2 gene. Meningiomas common in NF2 syndrome. 50–60% sporadic, have NF2 mutations. Others involve TRAS7, KLF4, AKT1, SMO, often skull-based, lower malignant risk. Higher grades acquire more genetic hits, TERT CDKN2A. Morphology. Usually rubbery, rounded dural masses, compressed brain but easily separated, can grow on plaque, sheet-like. Often gritty due to SAMA bodies, calcified whorls. Most are WHO grade O. Low recurrence aggression. Many histologic patterns. Meningothelial, fibroblastic, transitional, saminades. No prognostic significance.
Atypical meningiomas, WHO grade 3, high recurrence, aggressive growth, defined by increased mitosis, brain invasion, or specific patterns, clear cell, chordoid. Anaplastic malignant meningioma, WHO grade 3, highly aggressive, 1 to 3%. Resembles carcinoma sarcoma but retains some meningothelial origin evidence. Markedly high mitosis.
A papillorhabdoid variant's rare, grade 3, clinical features, usually slow-growing. Vague or focal symptoms, compression, common sites, parasagittal, convexity, sphenoid wing, olfactory groove, sella, uncommon in children. Moderate female predominance, 10.1 for spinal. Multiple suggest NF2, often express hormone receptors, progesterone, faster growth in pregnancy.
Brain metastases, cancers spreading to the brain, are also quite common, aren't they?
They are indeed. Metastatic tumors account for 14 to 12 of intracranial tumors in hospitalized patients. 5 most common primary sites: lung, breast, skin, melanoma, kidney, GI tract. 80% metastasis. Some rare tumors, choriocarcinoma, highly likely. Others prostate, rarely metastasized to brain. Meninges are frequent site. Can form masses or diffuse pattern, meningeal carcinomatosis. Hard to treat, causes nerve root compression, clinical. Mass lesions, sometimes first sign of cancer. Local treatment of solitary mets improves quality duration of life. Morphology. Interparenchyma mets, usually sharply demarcated masses, often at gray-white junction, surrounded by edema. Boundary well-defined, except melanoma. Resemble primary tumor. Immunohistochemistry helps if primary unknown. Meningeal carcinomatosis, nodules studding surfaces, nerve roots, often lung breast.
What about paraneoplastic syndromes? These aren't direct metastases, but remote effects of cancer on the nervous system.
Precisely. Perineoplastic syndromes are fascinating remote effects, where a peripheral cancer produces syndromes affecting PNS-CNS. Can precede tumor recognition. Mechanism. Immune response against tumor antigens cross-reacts with nervous system antigens. Spectrum of antibody targets expanding. CNS examples. Subacute cerebellar degeneration, Purkinje cell destruction, gliosis, inflammation. Often PCA1 anti-EO antibody. Predominantly women with ovarian, uterine, breast cancer, limbic encephalitis, subacute dementia, perivascular inflammation, microglial nodules, neuronal loss, medial temporal. Can have NA1 anti-HU antibody, often small cell lung cancer, NMDA receptor antibody, ovarian teratomas sporadic, or VGKC complex antibody. Eye movement disorders. Opsoclonus common. Children, often with neuroblastoma, PNS syndromes. Subacute sensory neuropathy, dorsal root ganglia inflammation. Lambert-Eaton myasthenic syndrome, antibodies against presynaptic calcium channel. Treatment. Immunotherapy tumor removal can help, especially for antibodies against cell surface proteins.
Finally, let's touch on familial tumor syndromes. These are specific genetic syndromes that dramatically increase cancer risk, including in the brain.
Yes, these familial tumor syndromes are inherited diseases with increased neoplasm risk, and CNS tumors are prominent features in several key ones: neurofibromatosis, NF1, NF2, and schwannomatosis, autosomal dominant, NF1, neurofibromas, optic gliomas, List nodules, café au lait spot, NF2, bilateral vestibular schwannomas, multiple meningiomas, spinal ependymomas, schwannomatosis, multiple non-vestibular schwannomas, tuberous sclerosis complex, TSC, autosomal dominant, hemorrhagiomas benign, neoplasms, brain other tissues, seizures, autism, intellectual disability common, CNS, cortical tubers, subpendymal nodules, subpendymal giant cell astrocytomas, benign, often cause seizures. Other body, renal angiomyolipomas, retinal hamartomas, lung heart tumors, skin lesions. Pathogenesis, TSC1, TSC2 mutations, unregulated mTOR activity, increased cell growth, mTOR inhibitors show promise. Morphology, cortical tubers, disorganized neurons, glia, subpendymal nodules, canal gutterings, subpendymal giant cell astrocytoma larger can cause hydrocephalus, von Hippel-Lindau disease, VHL, autosomal dominant, CNS meningioblastomas, cerebellum retina common, cysts, pancreas, liver, kidneys, renal cell carcinomas, pheochromocytomas. Pathogenesis, VHL tumor suppressor gene mutation, one is loss of VHL protein, major IF1 overactivity, excessive VEGF blood vessel growth, meningioblastomas, sometimes polycythemia, excess erythropoietin.
It's truly remarkable how a single genetic mutation can lead to such widespread and varied tumor development across different parts of the body, including the brain. It really gives us a window into the genetic underpinnings of cancer.
Indeed. CNS tumors are incredibly diverse. Their impact often depends on location more than just malignancy grade. Gliomas are common, with IDH mutations now critical for prognosis. Meningiomas are often benign, but can be complex. And these familial syndromes reveal the deep genetic roots of many CNS pathologies, offering crucial diagnostic clues and, increasingly, targets for future therapies.
Well, that was an absolutely incredible deep dive into the central nervous system. We've covered so much ground, from the fundamental ways individual cells react to injury, through the complex dance of fluids and pressures, to the mysteries of development, the brutal reality of trauma, subtle threats of vascular disease, the array of infectious invaders, the intricate failures of demyelinating conditions, the insidious progression of neurodegenerative proteinopathies, and finally, this vast landscape of brain tumors and genetic syndromes.
We've truly seen how a single molecule's misstep, or an external force, can trigger a cascade of events leading to devastating conditions. And how knowing the morphology, the actual structural changes down to the cellular level, can be the key to understanding and, hopefully, to future treatments. It's a field of immense complexity and vital importance, really.
What stands out to me is just how interconnected everything is within the brain, and how, despite its incredible complexity, it often has very predictable, if sometimes devastating, responses to a wide range of insults. For you, our dedicated learner, I hope this has provided a profound new level of understanding, perhaps moving you closer to that kind of mastery of these core concepts. Maybe it leaves you wondering how many of these seemingly disparate conditions might, at their core, share even more fundamental mechanisms that we're only just beginning to uncover. Something truly fascinating to mull over until our next deep dive.
Thank you for joining us on this essential exploration.
Until next time, keep digging deep into knowledge.